Good morning. We are all welcome to this Saturday session of the workshop, which is going to be hybrid, both hands-on, and some participants are joining, or most participants join virtually, while few are joining physically. So we have Dr. Muhammad Ali Abba, who will take us to the practical sessions of what we've seen in the last 2 weeks in terms of assessments of balance and posture related to your activities and balance. So thank you all for joining and happy listening. Over to you, sir. You are welcome.
Hello, thank you very much, sir. Good morning, everyone. Good morning, the virtual participants and the physical participants here with me. Thank you very much for having me once again. We had previous presentations on what today we'll be looking at the practical sessions. We had 2 webinars in the past 3 weeks, and 3 weeks ago and 2 weeks ago, we had 2 sessions respectively. And today, by God's grace, we'll be looking at the practical demonstration of each of the instruments that were discussed theoretically last time. Before commencing, I observed, yes, that some were not part of the theoretical presentation last time, and we just want to, for those, please, for those that were here last week, 2 weeks ago and 3 weeks ago, please, you should be patient with me. I will just go through briefly to highlight some things before going into the practical proper. Please bear with me. Because I want to carry everyone along. Sorry for the inconvenience. First of all, this is a video I found on the net on a child practicing balance control on a gym board. That his target is to be able to ride a horseback riding. Probably that is his ambition. in the future. And so just to call our attention, which I'm going to discuss in a bit, when conducting or when administering some of these assessments or some of these tests or some of these skills, we'll look at the characteristics of the participants, the previous, the current and previous activities or occupation or the things one is involved, the age, and many other things will be looked at. So for this individual, for this young man, probably some of these tests will be applying for patients, will not be applied for this young man. You can see he's standing on a board. So it means he can stand on a wobble board, he can stand on so many compliant, so many difficult terrains or so many difficult surfaces. So, but what we look at is most of or significant number of the skills or instruments we look at, they are developed for patients, even though some are also assessing healthy individuals who are apparently healthy, but could be some special population like elderly, yes, which also they have impaired balance. And it could be that some of them could be tested for screening for certain activities or certain occupation that may require such high level of activity or balance or task. Hello, sorry, I'm back. Sorry for the interruption. I was notified that some could not hear me, so we are trying to verify. Please, if you've been hearing what I said for the past 5 minutes or so, please let me know so that I don't miss out on some participants.
Yeah, I'm not hard, but I think it's my problem. It's earpiece I really use.
Okay. Okay. Thank you, sir.
So your voice is okay. There's no any problem.
Okay. Thank you, sir. So this is just about the video that I just demonstrated. So we'll go to the presentation proper. Sorry, like I said, I'm still taking us back to the theories. Previously, we have defined which Dr. Jibril Samani himself was the one that made this presentation. We have talked about balance, we talk about postural control, balance control, the importance of balance. Why is it important in our day-to-day activity? And we have talked about how it maintains specific posture alignment in everyday activities we do, how it facilitates voluntary movement, because without this balance, we won't be able to transition from posture, from sitting to standing, to back to sitting, to ambulate, to sit, and back to different postures. Then reactions to external stimuli, when there is a disturbance, we're able to adjust and take ourselves back instead of falling down or sustaining injury and many other things. So this is just a brief about the importance and the importance of the assessment too. It is very, very important because we need to identify whether or not there is a balance problem. As I've mentioned, and in many presentations I've done or in classes, especially in neuro, I always say that, first of all, we need to check whether there's a problem or not. And there are quick ways we can do it. Then we now check, okay, this is the problem, and we now probe, we now assess further and find out where the problem lies and what is the level of that problem. Then we'll know how to approach the how we approach in terms of treatments, and we'll also see how we are progressing or otherwise, and we need to change or we need to improve or we need to look at the management. And also for prognosis, we're able to know that at this level of balance, at this part of balance that is impaired, this part of the body, which we will talk about trunk balance, maybe in the second session of the webinar today or the workshop today. We'll see that there are level of balance or impairment of balance that we know that these stroke patients will be able to recover in much faster time. Or when the balance is very much impaired, we know that there's going to be a delay in the progress or improvement. Then generally, yes, assessment of balance is to check for risk of fall. We want to involve our patients because they are going to be, when we are managing patients, they are going to be involved in various starting positions, ranging from lying to sitting, standing, and mobility will also be involved. So if what we want to know whether we can subject this particular subject or patient to that certain position, then we'll test. Or we want them to get around in the environment or to get into the community, then we'll be able to test from the from our various assessments. We're able to know. Then you want to give intervention. This is the approach you want to use based on those impairments the patient presents. You'll be able to personalize this treatment. Yes. Consequences of balance. I've just mentioned in the previous slide that one of the things that we assess and want to prevent is fall all the time. When we talk about balance, we always think of fall. So when we assess balance, we are not just only knowing the prognosis. We are not just only having an idea of the prognosis. We are not just having idea of progress in our treatment. We are also having idea of risk of fall. And when there is fall, what happened? There could be a lot of injuries, especially for older individuals. They could try to land on their outstretched hand, which is already started developing osteoporosis, and fracture is looming, and many other injuries, fractures, head injury, spinal injury, and a lot more could occur. So with lack of balance, we have poor gait, abnormal speed, limited walking. Somebody has to use walking aids. Somebody have to reduce the distance that the individual has to go around. Want to go for a wedding, want to go for an event, want to get employed. All those things could be limited because of lack of balance. So this is how serious the consequences of balance impairments are. Yes, I've just talked about it, which is decrease in activities of daily living, and in larger notes, the participation also is restricted. Then poor work performance, of course, we'll be able to be efficient in the workplace because of limited movement or mobility. Decreased socialization, I've also mentioned it. One will not be able to go to attend many social activities, wedding of friends, wedding of friends, children or siblings or co-workers, and much more. then this will have consequences of negative psychological impact, because when all these things are surrounded by an individual, there could be risk of things such as depression because of lack of mobility due to lack of balance or balance impairment. I've also taken time last time, the previous presentation, to talk about the utilization of balance assessment. And I was able to bring this study last time to discuss on a study here that was published at Ontario, which surveyed 369 field therapists, asking them on the utilization of balance assessment. More than 80% of the respondents reported that they regularly assess more than 60% of the time. That's 80% of the participants, the physios reported they use it more than 60% of the time they spent in the clinic or managing stroke patient or neurological conditions rather. So, and these are the domains that they assess based on the balance. Sensory systems, cognitive contributions to the balance, and reactive control are the major contribution that they assess to balance. And this is a summary of the study of assessment by the physiotherapist based on specialization. And I remember I took time to explain how each specialization were having a format of their assessment. And I was talking about how neurology and geriatrics, general rehabilitation have majority in assessment of cognitive contribution to balance, while orthopedic, which I've said is very much expected, that they may not look into that aspect of cognitive contribution to balance. And we can see also on the second to the last column, row, sorry, we can see sensory system, and we'll see also that neurology, geriatrics, and also have a significant contribution. So we can see that it depends on the specialization and depends on the patient that they have, that we see in the clinic, then we choose on what to assess on the patient. That's based on the balance, and also to manage what is impaired in that balance. And the most the most common instrument that was used for those study for the participants were single leg stance test and back balance scale, then time up and go test. I mentioned last time too that I tried to search for Nigerian studies and I couldn't find, but this is a study not just on neurological conditions, on balance, not just on balance assessment. It's a study on assessment of standardized stroke outcome measures on among stroke survivors. So it's not just balance. So balance is just one of them. I said last time, I said this is the closest study to what I am looking for, and that's why I brought it here. It's not directly related or relevant, but because it's about stroke patient and it's about use of standardized measurements, and also it's about use of it. Also, one of the items that they have asked question that they have interviewed is assessment of balance also. So what they reported, Okonkwo et al. In 2023, what they reported was there is a low utilization of standard outcome measure. And they said, and they have run chi-square test of association, and they realized that it is this low utilization is associated with years of experience. That is younger physiotherapists that are at entry level, at internship level, or entry level, or early career physios are the ones with least usage of these standardized outcome measures. And also those with lower qualification, that is with a basic physiotherapy first degree, have also lower utilization of these outcomes according to the study. And the barriers also to the utilization is that workload. Yes, some of these we're aware of them. Some we may not be aware of the full administration, but we could be missing out. I mean, the barriers could be workload. Yes, we have a lot of patients waiting for us in the morning already before arriving office, and taking time to assess using these and as outcome measures may take longer time and may delay the management and may delay other patients. Yes. Then lack of, maybe there's also small workforce in the department apart from the high number of patients. So lack of familiarization, that is also, which we could see is associated with low years of experience and lower qualification, not low qualification, sorry, lower qualification, that the participants are not very much familiar with the usage of this instrument. Then lack of availability, that most of them have to, they are paper and pencil skills, of course, that they have to be printed and they have to be available for each patient, which needs resources for those things and so on. So that's at the simplest of it, printing skills, not to mention the ones that will require sophisticated instruments or items for administration. So we've already started talking about some items during the presentation of the tables in the study I've discussed, that balance is not a one system activity. There are a lot of systems that are involved that come together to give what we know as balance control. There is musculoskeletal system, the bones, the muscle need to be need to have enough strength, the environment, of course, the motor coordination, the sensory, the visual, the vestibular system, and many other things contribute to it. This is just a summary of what I've just talked about. When we talk about the sensory, we talk about the vestibular, the visuals, the proprioceptive, the motor, we talk about the strength, coordination, reaction time, and many other things are involved. So if we want to assess balance, we have various approaches. I've talked about this already. It's just to go briefly and talk about them. We have various approaches, like I said. We have the functional approach, we have the system assessment approach, and we have the objective assessment. I remember last time during the first presentation, my colleague, Dr. Jibrin Samai, talked extensively about the objective assessment, which he talked about posturography and other ones. So we have the functional assessments, just like functional reach tests, time up and go, and many of them. The one leg stance, the run back test, and many of them. This usually, then we have the system assessment. So let's just talk in brief about the functional assessment. Functional assessment functional activities are balance and spin dependent, of course, as we know. So these functional assessments of balance are most of the ones that are readily available to us, and they're easy to use. They do not require any expensive equipment. They are usually quick to administer within a few minutes, and they are able to predict for many patients. However, they have a lot of limitation, that they are subjective. Even though we see them as objective, they are, yes, to some extent, if we dig deep, they are subjective because yes, they have high intra-rater reliability. They have very good psychometric properties, but even as that, there's a lot of other limitations, like ceiling effects. Yes. Then we have also responsiveness also, which is also limited in some, not all. Then they cannot specify what type of balance problem is they cannot specify which system, which area of the balance, because they are just assessing just one function of the balance. So the objective assessment, they could be able to identify, differentiate which were like the posturography and many other things, and they are very, very much objective. Then we have the system. This system, like I said, that they try to identify which system, is it sensory system is affected, or is it the motor system? Is it that the strength is, the muscles are weak, lack strength, or which area they usually identify in this? And like I said, example of them is the Horax best test, the balance evaluation system test, which is the Horax best test. Yes. This system assessment, like I said, they are categorized into system, biomechanical, sensory, motor, and so on. The same thing with the PPA also, physiological balance profile. They also look at sensory, which is the vision, the cutaneous sensation, motor, which is, for example, the muscle strength, also reaction time is also motor, and so on. So this is just to mention a few about the system that we can see is entirely different, like just as, and what you do is most of the time you see that they combine some of these individual assessment that we have. We have individual assessments such as for example, functional reach tests, wireless standard. So some of these systems they combine plus other systems. Some of these skills, sorry, they combine some of the tests to assess various domains, and they also combine with other system assessments. So yes, back to our discussion. So there are approaches, whether you want to look at the functional assessment or you want to look at the system assessment. We want to go into the objective, which are very expensive, not readily available. There are a lot of challenges, although they are objective, but issue with, for example, in our own context, we look at electricity, we look at technical know-how, we look at maintenance also, and look at how to keep them working safe, and so on. So even though, yes, these are the objective ones, but like I said, the most readily ones we have that are available are the functional assessment. So let's look at, because that is what we discussed largely last time, and that's what we'll be looking at is the functional approach. And there are also another approach to the assessment, but largely here I'm talking about the functional approach. We will look at it as a static balance or the dynamic balance. So, or these are just example of few which we'll be looking at today by God's grace. Then we have the dynamic balance assessment. These are also few that I mentioned. Then we'll also be looking at the trunk assessment, also the practicals by God's grace today. Then these are some examples too. Then I think they were all discussed. The first one was discussed by me, and the last three here on trunk assessment were discussed by Dr. Jibril Samani. But today I will be taking the first three: trunk impairment scale, trunk control test, and functional institute test. Then we'll be looking at also the dynamic balance assessment. We'll look also at the static balance assessment, and some of these things we'll be looking into. Then there are some tests that neither fall within dynamic or static or trunk assessment. The trunk assessment also could be static, and could be dynamic too. So, but some tests don't fit into whether static or dynamic. They could fit into combination of all this. And for example, one of the tests is back balance scale, and we'll also be looking into it probably in the second session of today. Yes, but before we commence any assessment, balance control assessment. One of the reasons that we have mentioned is we assess balance because we want to predict risk of fall. So, and some of these tests will provoke the while administering will provoke the possibility of fall. So we don't want a situation whereby just in trying to assess a patient and the patient now got into the situation that we want to prevent. And this could be a vicious cycle. The patient fell down and will not want to be part of that assessment again. Will not want to be part of that posture that you are trying to get in. So this could be a problem. Then, according to Center for Disease Control, CDC, that just like stroke, risk of experience of fall, first experience of fall, or person with an experience of fall has another risk of risk of another fall. So, as much as possible, we are trying to prevent. So while making the assessment too, we need to prevent. So that's why I just want to talk about some things that we need to consider. First of all, establishing the diagnosis. Yes, diagnosis has been established, or the impression. We already know that this is the problem that the patient is having. Then we, by our knowledge of physiology, anatomy, pathology, and all things combined, we know that this patient, these are the likely things, these are the likely impairments that the patient is going to have. Then we know that we cannot subject this individual to certain things. We can subject this individual to certain things. We know what to assess, and we know how to. Then medical history. Some of the drugs the individual is taking maybe could affect our activity. Maybe he's taking some drugs that sedate him or her. Many other things we get from the medical history. And I'll talk about history of falls too. When that individual has history of fall, has already had fall previously, it will take a lot to get that individual into that test and into that position that we want to do. Then our physical test that I've talked about, we need to know that yes, the motor system is intact. Yes, he has enough strength, he has enough coordination, has enough this and that before we go into then preparation, right from the physiotherapist preparation, the patient preparation, explaining the scale or test or procedure to the patient, knowing what he's expecting and what it means if that this is what is obtainable when he's assessed. Then the choice of instrument, knowing that this instrument is valid for that patient, it could be used and it will give meaningful outcome to that patient's condition. Yes, knowing that this is the appropriate, this test or this scale was developed for this category of patients, or it's developed for some group of individuals or some group of patients, but it has been validated for this particular patients. Then we know that yes, we can use it to assess them. Then what are the procedure of administration? What are the scoring? What do we get? What is the meaning that we get out of this assessment to the patient? What does it mean to the entire condition or to the patient? How can it help in our management? And so while administering the test or the scales also, the physio need to be around to give support, also to prevent fall. Then if there is need for additional physiotherapist, 1 or 2 also to come by is also important. Or there is need for not just the external support from physio. Do you need external support from parallel bar or from harness or from assisted devices? For example, some tests like time up and go allow for patient or individual to use their own working device, but this needs to be properly documented that the patient had time up and go test with a walker or had time up and go test with a cane and so on. So the clothing, is it convenient to go into that test with that particular clothing, or is that clothing that the patient will just trip while conducting assessment and they will fall down, or will limit some movement because of the nature of the clothing? And the footwear also. The footwear could not be convenient for the test. So all those things need to be checked in also. The environment, is it well prepared for this? Is this a test that involves mobility of certain distance, and there is no any obstruction or any problem that will come along the way? Then it's well lit if there is need for the light. For example, in some tests, you need a place which is dim, and so on. So that's why we need to know the test, and we need to know how to appropriately apply it for certain patient and all the factors involved. Then it's best to start from the lower position up to the higher, the upright postures. Like in some tests, for example, in let's say some tests, yes, back balance scale, or let's say trunk impairment scale. There are some levels that if a patient has not been able to achieve any other thing, you just score him 0, and that's the end of the test. It means if he cannot do this, and most of the time you see is at lying position or sitting position, as the case may be for which of the tests. If he's not able to do this, then they will say, ask you skip to so test, skip to so stage, or that's the end of the test. So it depends. So most of the time, for tests that have different positions that are being transitioned or changed, some are conducted throughout in a sitting position, some throughout in a standing position, some will involve changing certain positions. So most of the time you see those tests, not all of them, but some, you see that they start with sitting. If sitting is not good, then they will just say skip to so stage, or you just stop the test because the patient cannot go further. So these are some of the things that we may consider. Yes, we know the ability, we know the limit of what the patient can do, from, like I said, from the condition, from our knowledge of the condition, we know that this is probably the impairments that this patient could have, and will not be able to do this task. And that's why I showed a picture of the video of the boy pretending to ride a horse on a gym ball. Yes. So the age, the previous activities, if somebody is an athlete, somebody is on a sedentary lifestyle, if somebody is the current occupation, previous occupations, all those factors matters in the assessment. Yes. So now we can start demonstration of the particles. I divided it. We are taking the functional assessment approach, of course, and we have mentioned previously that we'll look at the static balance, we'll look at the dynamic balance, and we'll look at the trunk aspect of the assessment. The dynamic and static balance I'm talking about, they are usually in a upright position, in a standing position. They're usually involving lower limb. Then the trunk, that's why it's separated. It also has the static and the dynamic. So the static and dynamic classification I have in the beginning is just for the lower limb involvement. Then we have the trunk assessment, which also has its own static and dynamic also. Some of the tests assess both the static and the dynamic. So static, yes, we assess step test, yes, which is one of the assessment which we'll be looking at now. And the instruments required are usually the step we have in our normal gym or our gym in the clinic. Yes, they should be around 7.5 meters centimeters high. Sorry, in most cases. Yes, if the appropriate measurements are done. So 7.5 centimeters. Then number of steps are assessed in 15 seconds. How many steps an individual is able to do in 15 seconds? So at first, a patient is not able to stand unsupported, then is scored 0. Or is not able to stand, yes, then the individual or the patient will step using the non-paretic first, then will step using the paretic second. Then stepping using the non-paretic should be around 15 steps. Then stepping using the paretic side should be around 10 steps. So if he's able to do this, then it means that the patient is at low risk of fall. But if he's unable to do it, then it's at risk of fall if he's involved in an upright position. Of course, at the beginning, he's not even able to stand. You will know that, yes, there's going to be a problem in any upright position. There's going to be a risk of fall. So let's look at the tests. Maybe we can look at them one after the other, or we'll take maybe 2 or 3 at a time, and we demonstrate.
So that we screen sharing. That's my base. How much? So we have against the stress that we have. Yes, most of the time when we check the stress in our body, we see that one side is smaller than the other side is larger. This cost of the smaller steps actually it's a standard. Yeah, you have a standard. So now this measure yes, to ask patient and but we are talking about safety. Bringing the patient to work is another method that when it's safe. Bringing chair, patient sit on and when there is a patient will fall down, you go back, like you walk here and have yourself now and yes, how to speak. One of them, and one of the next thing that you need on the top of the measurement is time. You time for 2 seconds as fast as he or she can, as fast as he or she can, to step up and down, one leg, then switching to another leg. So 2 seconds, the first thing calculation. Okay. Are you ready? If you didn't understand, you have explained to understand. Most of the steps allow for. Are you ready? Okay. Let's start. Are you ready? Let's go and start. Okay, not the so you can see the scoring I gave there 10 and which is for patients. For apparent speakers, so that's why at the beginning of the presentation, I gave somebody who's getting better before you stand on before. So can see for apparent speakers, but for good patients, let's so let's go again. Let's see how many steps I will use to do it. 10 seconds here. So you can give me the instruction. So maybe you should give it, yes, you give a head start. But one, I mean, you should give instructions in the steps also so that when you say start, they're ready. Ready? One, ready? After 3. 1, 2, 3. 1. Then left. This is using handheld or using support. If at all you want anytime. Okay. Are you ready? The right lower is the number. Okay. Yeah. Are you ready? Go. And
17.
Okay, so let's go. Are you ready? 1, 2, go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13,
Stop.
14.
Oh, that is the step test. Yes, I forgot to mention this too during the introduction. Some of these tests are not all the teams also forgot to mention you need fire back activity and then back to the question. You ask a question on whether what is the highest of all or what is the cost of the highest of all, low of all, and maybe high, medium, and low. Yes. Some of these tests, the way they were developed and the way they are conducted, some of them don't have category. Only what they have is what you have risk or not. Even some you see them with a range of cost, maybe some up to 100. But they just tell you person has low risk, low risk. They only tell you that when he has this, he's safe. When he has less than this, there's a support. But they don't have this category. Some have this category. We'll be looking at them in a bit. So that's why I said the choice. If you want to screen, for example, step tests, run-back test would be a screening test for you. To know that yes, there's a problem with balance. Then you want to go further and know the category, then now go extensively to which test do you want to choose and how do you want to see if you have categorized it into various groups or various levels. So I've always mentioned it in neuro assessments. Most of the time we have assessment that we have for screening. You want to test whether there's something or not. Like, for example, in my area of interest on, let's say, you want to check for cognition. You don't grab MOCA test, or you don't grab MSE or all those skills and begin to subject patient to almost 20 minutes of assessment. And at the end, you say that patient doesn't have cognitive. I would say you have wasted your time. you have practiced the test with the patient. But there are some screening, some quick tests, for example. This, thank God you are bringing up this question. So, yes, so yeah, that's why I like this interactive. Maybe sometimes you have something in mind, let's say you have a slide, or one can say something like you have an idea, you can also add to the discussion. So there could be some quick tests. You just run, it's just easy. You ask patient to stand for run back test. It's just easy, 15 seconds. You just run a test for balance using the step test, right? But for example, just asking a patient to run through back balance scheme, which would take a very long time for you. So from this, we now know that yes, that's for example for Trump, where I want to talk about Trump, the way the patient sits. We now know that the Trump is prepared. You can go for that to check. So most of the tests, there are some in the category of screening, but there are some in the category of evaluation. They go deep to find out where is the problem, the level of the problem. Some of these are tests, just 15 seconds. Rumba test also similar. So can we move to
Yes, that is step test we just demonstrated. Now, I just want to add that there's a modification, the sitting step test. But this is a new introduction. It's still under development and validation, psychometric properties, procedure, and so on. But this is just to add to it. Then The next test we'll be looking at is Rombach test, which is also a very familiar test. The position doesn't require any equipment or any instrument. For the step test, we may need step, we may need a timer and so on. For the Rombach test, we will just need a timer and just the environment that we need that we assess the test. And the position of administration is for the patient to stand erect with arms held by the side or crossed in front of the body, standing with the 2 feet together and the eyes open. We assess if the patient is able to withstand this posture or this position for 30 seconds. Then we say he has low risk of fall. But this can be probed further. I've mentioned that some of these tests are sometimes for screening, and over the years, they have observed the limitations of this test. Over the years, most of these tests have undergone modification. I just talk about the step test in sitting, but most of these tests have undergone modification, and there are modifications to Rombach test also. First, you start with eyes open. Is able to pass, or the patient fail. You cannot even go further because with eyes open, you have removed visual system, and the patient is struggling to stand. I mean, with visual system, with auditory system, the individual is able to stand. Then you can go further by removing the visual system, which is also which also contributes to balance. Then we can do this in eyes closed, which further challenge the test. Then another modification is to disturb the balance of the patient by or bring about perturbation, nudging or pushing the patient from all directions. Then another modification could be using a compliant surface. It depends on the patient, it depends on the individual, it depends on the person. Using a carpet, using a tile, they could all have different effects because we know that tiles are slippery, or marbles, they are slippery. But with carpets, they're usually there will be friction, and that's why you hardly see in our gyms. You see carpets. I mean, you hardly see marbles or tiles. So, but in addition, we can use. It depends on the patient or the individual. If it's an athlete, you can use up to maybe wobble board and other things. But just simple placing the individual on a mattress will affect the balance because you struggle to stand on the mattress. So you can progressively make it difficult just by standing on the surface with eyes open, with eyes closed, perturbations, then changing modifying the base of support to have a compliant surface, have a surface that will affect the stability. I've just talked about, for example, using the mattress and other things will affect the stability. Also, the position of the upper limb, like we can see on the picture here. Sometimes we can ask the patient to raise the upper limbs to a level of 90-degree shoulder flexion. Then that will also affect the balance. So these are some of the modification. Then by extension too, there is another modification which involve standing heel to toe. So this is almost like a tandem stance. Standing heel to toe, one foot directly in front of the other, Then patient crosses arm over the chest, and the weight is distributed equally over the feet. Then you assess for 30 seconds. Then you check whether the patient is able to hold that position for 30 seconds or not. Then you know whether the patient has a risk of fall or not. So we can see this demonstration now.
That's the look why he was subject almost all time. I deleted it. So just like what you have said at the beginning, patient will stand with 2 feet together, his arms by the side. Use a patient with balance and for all we see that we're able to less difficult. But somebody with some injuries, athletes that have injuries in the joints, maybe I talk by second and maybe so when you stand arm by the side, time for 30 seconds, using your stopwatch. 30 seconds. Patient able to maintain it. 30 seconds will be short time. But I mean, also we can see as a short time. But for patients, will be probably may feel like the road is either patients will start for the road. Yes, you will see many patients will prefer sitting on the time. So when it's subjected to the new posture, new direction, then be of course. So asking the patient to stand together, arm by the side for 30 seconds. Count 30 seconds. Able to do it. Yes. There's no risk of fall, but you can see for that as check. Ask the patient to close eyes. Seconds. Able to do it. Then like hopefully the support. But some at this stage will begin to talk because we have removed the visual system. If you are talking about the visual system that's so when you remove the visual system, then they know how to maintain the parts. Then you trouble. They see the sway with the arms, looking at where to go. Then about the safety, yes, close to a chair, close to a wall, or in a parallel bar, and other things. It's much desirable because of you want to prevent fall. I mean, you want to prevent fall. You want to prevent fall by assessment. So not just your assessment now causing fall, which could be a big problem to your further assessment and your further rehabilitation. So we talk about the modification and bring a compliance office. Not just bringing a compliance office, just asking somebody to step on. Another surface is also affected. Then activations. Yes. Pushing the patient from one side to the other. And we have talked about balance strategy in the previous presentations. Last 2 weeks, presentation. Mr. Mani has talked extensively about balance strategy. Even from balance strategy, you know how patient is struggling with balance. We have the ankle strategy, and we have the hip strategy. When you have participation, you want to maintain, or when you have you have lost your balance, trip, you want falling down, that's the way you cover yourself through this strategy. So we have the ankle, we have the hip, we have in some literature you see the arm strategy, and the final one you see is stepping. You know, step. Another person step with that. It's almost for some will not be able to step. They will just fall down. So that's why you need to monitor what strategy the patient is involving. And you now know that they have gone beyond the limits. I've done that in previous presentation. And a bit of stability. And that's why while I was rushing through the presentation, I showed a picture of my Jackson, in which he was showing us when he was doing his dance. He's going almost up to 45 degrees while dancing, and he's not falling down. He has gone beyond the limit of stability. We know the limit of stability is nothing up to more than 10 degrees. Somebody can go and 4 degrees down, and not more than 5 also degrees to the side. But we have almost 45 degrees that you see them on the stage that. So they are using some kits to be able to maintain those forces, using the shoes, the floor, and many other things like this. So you watch the strategy that the patient is for. The ankle strategy, the hip strategy, the arm strategy. So then you now know that whether that patient is about falling or is still at good stage, depending on the strategy. Right. Yes. Then the participation is then. Okay. Maybe we can talk about tandem walk tests. And I saw the of the numbers. Right. Okay. For stand up. Feet together. Yes. Arm by the side. Yes. Stand for. Should we tell you? Yes. Okay. Let's see. Yes, we'll time you for 30 seconds. Are you ready? Yes. And okay. But for safety, this is a demonstration, but as for real patients, you stand close by and watch how the patient is also standing for safety and also watching the same thing as watching whether it's passing or failing the test, and also watching for safety whether he has gone beyond what is able to do. But you have talked about it, you have demonstrated to the patient, and you have told him that whenever you feel you want to fall, you can go back to your seat, you can inform me, you have a parallel bar to you, close to you, you can hold it. But when you see those, when you see those reactions, you know that the patient will not be able to complete the task. Yes, that means he has failed the testing. So you can close your eyes. Yes. This way. Yes, and see for time for 30 seconds. It's able to do it 30 seconds, then it's okay, has no risk of fall. So, but we can progress it by giving activation. And see the ankles strategy. Right. You can give contribution. Yes.
So this is about number test. So you can go to, can I share this? Just temporarily, let me share. Can I show you? Yes. Yes, sure. Okay. So the next test we'll be looking at is the tandem stance, which is still also static balance assessment. That's the patient to stand on a narrow base of support. That's by asking the patient to bring the feet together. Then you can demonstrate in all of them. You can demonstrate. You give the instruction. You tell the patient how you're going to do the test. Then we talk about safety. I've been reiterating this safety because we don't want a situation where in assessment then you are caused there. So you stay around the patient for safety and ask the patient to place one foot in front of the other, like tandem. That is the tandem stance. One foot in front of the other. So you time for 15 to 30 seconds. If you are not used to it. So we are progressing gradually. Okay. So we are progressing gradually. This is the tandem stance test by placing one of the other in front of the other. Yeah. The time for 15 to 30 seconds. Yes. The 2 feet. I mean, yes, it should be distributed for the 2 feet, and if the affected knee forward or the unaffected should be at the front or at the back. Most of the time, what we emphasize is the comfort of the patient. The hip prefer how best the hip prefer to do this. For example, in a test like time up and go, you ask him which side he prefer to turn. So the same thing. Like we'll be looking at one leg stance in a bit. You ask him which of the foot would he prefer to stand on. You know, apart from affected limb, some may not be hemi patients. We're only looking at stroke patients. Some may be hemi patients. We will have Parkinson's disease patient. We will have many other neurological conditions. So we have also dominant limb, not just the limb that is affected. We also have the dominant. So we look at the most preferred position that the patient will want. We ask him to do it. At times, stroke patients go by standing. Once they stand up, then they look to use the affected to move forward, especially maybe at the initial stage of the yes. Maybe I don't want to talk about management, but I can explain some of these things.
when you look at stroke, when you look at stroke ambulation, what they do is you look at under gates, you look at the period of double support and the period of single support. That's you look at aspect of stance and swing phase. Stance phase takes majority of the gait cycle. It takes about 60% of the gait cycle. Most of the time we spend time on support of the leg than on the swing phase. About 60% of it. And what the stroke patient have, which is peculiar to them, is shortened stance phase. When they walk, immediately they step on the affected, they go back to the owner. That's what you are trying to say, right? Immediately they go on unaffected, to the affected, they'll just take a few fraction of time.
Yes.
Then you go back to the, that's why you hear this.
Yes.
That's why you hear this. The moment you go on the unaffected, the affected, you go back to the affected. So they spend most of the time on it. So that's why during our rehabilitation, we always try weight shift on the weight distribution, weight shift on equally affected and unaffected, rehabilitating distance, most of the stance, and all these things about gait rehabilitation. But that aside, we are only talking about assessment. So the next steps we'll be looking at is one leg stance. I'll just talk about one leg stance. I think this will answer your question. You look at the most preferred, how the patient wants it better, the way he most preferred it. Then you ask the patient to stand on that leg. There are some studies I know from a professor I know has taught us that sometimes it's not even the dominant. Yes, that's in his longitudinal study. He was able to find out that apart from the dominance, right and left leg, or right and left lower leg, that people, irrespective of whether it's our right is dominant or left is dominant, people most of the time prefer to stand on right. That is a study. You can check. Professor Thomas has a study that he has done for a very long period of time. But it's subject to review and many other things about appraisal. But this is one of the things that was found. And talk about the stability of the right hip. When you look at how the lower limb, the left limb is going beyond the other, you see that the right is more stable. So, but that's aside. So you ask the patient on the most preferred lower limb that he wants to stand on, you ask him to stand. So with time, you ask him for with eyes open. You can also progress with closed eyes. So hands on the hips, eyes open, stand unassisted, but you stand around the patient for safety. It's close to a chair, it's in a parallel bar that can easily hold to prevent falling down. There's also support either in front or in the side to prevent falling down. And then ask the patient to stand. The patient feels when this foot that is flexed touches. If he does this, then it's cancelled. It means they have failed the test. And he does this. Or when the arms lift the hips, supposed to hold it, then he has failed the test. or is unable to do it for at least 5 seconds. The question you ask, the time is maximum 20 seconds. Yes, 20 second maximum you can access. That's one leg stance. Ask the patient to stand on one leg, of course, on the preferred lower limb that he wants to stand for maximum of up to 20 seconds. So there are different stages of the scoring. First, he's not able to do it for 15 seconds. But how is he unable to do it? When you remove the hands off the hips, then he has failed the test. Because he's looking for something or changing the position to maintain the balance. So when the arms leave the hip, or when the leg touches the floor. Or when touches the lower limb that's giving this touches, or it touches this limb giving the support, or the limb touches the floor, or the arms hit the hip. These are all ways that you find out that this patient will not continue with this, or is unable to do it for just 5 seconds, standing 1, 2, 3, 4, 5, and then he has risk of fall. So we have just looked at one leg stance. Maybe you can try. I can look for maybe 10 seconds, but more than 20. Or maybe we should tell you we have 10 years. we have a stopwatch. So let's time you.
For stroke patients, they're always prepared or unaffected.
Yes.
On the unaffected.
Yes, they can do that. Oh, it's okay, they can do that. That's the preferred one. That is also telling you that if they could not do that, that is the preferred limb. It's telling you a signal that that limb cannot maintain the posture in standing and also in walking. So that's where they move their shift. That's why they shift their weight almost all through the gait during. So let's start. Are you ready?
Yes.
1, 2, 1, go. And stop. So it's okay. So it's only the tandem stance that was giving you difficulty.
Well, at the first time, weight distribution. It's true.
Yes, I've talked about the footwears also. This is also.
Okay.
Then yes, the next test we'll be looking at is Fukuda step test. Fukuda. I've talked about it last time, and I even asked questions from the audience who are from the military background, and we had some interaction then. I think last time we were having the presentation. So this step is checking amount of rotation, angle of rotation that individual gets involved after the completion of the test. When the patient or individual conducts this test, it's expected that it's going to be rotation. How much of rotation is that's what tells us that there is a problem or not. So individual will be asked to do 50 steps or 100 steps, and it's like what I was interacting with the military participant last time. It's like you are marking time. Like marking time. You are marching in the sport. That is not the simplest example. However, some of the requirements for this test is to have a cycle, 360 degrees cycle, and to stay in the middle. Maybe have it calibrated into 30 degrees, which we don't have it. So we are going to just do it by assumption. So assuming we're in the 360 cycle, calibrated with 30 degrees, then we ask the patient to hold the hand at 90 degrees. There are variations. Some ask the patient to hold the arms at 90 degrees, some will not. It depends. You will see this variation. So ask the patient to make 50 steps. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, up to 50. But this is going to be done with eyes closed, blindfolded. The patient will not be able to see the environment while he's making these steps. You do up to 50 steps. Or you can choose 100 steps, but 50 will be easier and will be simpler to do. So if you choose 50 steps, the displacement will be around, in diameter, will be around 0.5 meters, or will be up to 30 degrees, or up to 45 degrees. Then there is a problem of risk of fall. If it's less than, then there is no problem. Maybe let us demonstrate it. Yes. I've already explained, and did you get the explanation? Yes. So make 50 steps. Yes. Okay. Are you ready? Yes. Let's time. There's no need for time. Stitch. Yes. Sorry. This step. This test. You make 50 steps. So count 50 steps. But you do it in eyes closed. But we don't have a blindfold. So we just assume you have closed your eyes. But we are supposed to blindfold you just to make sure that you are not seeing what you are doing. However, okay. 1, 2, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 49, 50. Stop. Open your eyes. Open your eyes. So we are supposed to measure the displacement. It has moved. Is it up to half of meter or more? I don't know. And from where you started. Yes, that's it. So that's why I told you there must be a mark of where you start and around 360 concentric cycles, two concentric cycles, smaller one and the bigger one. Then so we take the displacement, how much of the distance have we moved, and how much of rotation have we moved. This is more than 30 degrees. This should be around 45 degrees. I didn't know that already. Yeah, that's why I asked you to close your eyes. So you see this displacement and you see the rotation. Yeah, it's almost all the time there. Yes. But too much of it, then it's a problem. For example, if you choose 50 steps, then up to 30 degrees of rotation, more than 30 degrees of rotation, then it's indicating risk of fall. Or the displacement. If you check for 100 steps, it's going to do more of the displacement and more of the rotation. Then it's up to greater than 45 degrees, then you think of a problem. Then greater than 1 meter of displacement, then it's also a problem or risk of fall. But there is one thing with neurological assessment, not just balance assessment. And that's one of the things that when you see students writing researches, writing proposals, that there are problems. You see, sometimes testing could serve as treatment. So sometimes when you repeat it too much, you assess again, you are going to get better outcomes because the patient are now learning. So we need to look also into that whenever we are making assessment, especially neurological assessments. So most of them, apart from the maybe physical test of sensations, but most of these cognitive tests, while you are assessing and treating, most of these balance tests, almost all the balance tests, you are assessing and giving treatment. So when you repeat too much, you are already treating the patient, and you see the outcome will get better. So you know maybe when you start with this, which one are you going to assess after starting progression? You have your progression, just like how you progress exercises. You have your progression plan, because there will be a time this test will do and you have perfect results. Then you know which one to do next. Is it static, dynamic, or is it within the static? Which levels do you go? Within dynamic, which levels do you go? And so on. So we can we can use this. The tandem walk test. You ask the patient, just like the tandem stance, ask the patient to stand on with one foot in front of the other. So ask the patient to walk a line 10 foot long. So check how many errors that patient is able to make. Making up to stepping out 3-4 times for errors in the walking, then it's having a risk of fall. For example, the patient is now going back. You have up to 3-4 errors before going down the 10-meter walk line. Then it's also having a risk of fall. But this is a test also. And now you can use a parallel bar, you can go side by side with the patient for safety also. And that.
The meter is going to be
10 feet, you convert it to.
What about time?
No, there is no timing.
Speed of movement?
It all depends on the patients and so that's another. Up to 4. Then we can now look at the favorite time up and go. We have 3 meters here. Yes.
How many? 3 of them to make up.
This is 150 meters. Sorry, this is 1.5 meters. 150 cm. Yeah, so you have 1.5 meters. Let's start from this red. This is 150.
There will be one. Okay,
Just take it up to 150.
This is 150. Then next.
Yeah. Yes.
Okay.
3.
There will be
3 meters.
Okay.
the red line is
In the beginning of the
So we can't use that for the patient because it's going to So like a hard job, it's going to make it hard for them to make. Ideally, it's supposed to be like a math, right?
No, we can have a con or something for them to know that, because some may have visual problems, some may have so many other challenges. So we have something visible for them to see.
But they went to over this.
No, they want to just to go around. They are not walking and coming back. They are supposed to go around it and come back. So ask the patient to sit. You can use cone, you can use many other things. You can mark with a tape. But just for them to know, to see where they will start. So the chair should be around the mark of the 3 meter distance. So tell the patient, I want you to walk, I want you to stand up and walk, go around, come back and sit back. You go as fast as you can. Or you go, that is one of the subjectivity I was talking about. You see, sometimes the instruction will be go as fast as you can, come back. Or go at your comfortable speed and come back. So as the patient should, okay, instruction is stand up, walk, go around, come back and sit. So the timing is when the patient stands. Then the moment you stand up, then you start timing. The moment the patient stand up, then timing starts. Until when he sits back, then timing stops. It goes, are you ready? And this could be the instruction to the patient. Like, can you observe what I want? Are you ready? 1, 2, go. Stop time. 8 seconds. How many seconds?
8 seconds.
8 seconds. Okay. You can ask the patient to do it again. Are you ready? Stand up. 1, 2, go. And stop time. So you can do it 3 times and take average of it. 3 times, then you take average.
Okay, I want to ask for one clarification. Is it when the patient initiates standing or just as when he stands that timing?
When is initiating the timing, because we are also timing how it's standing.
So it's when once you give the instruction, go, you start timing.
You start time. Stand up.
The standing from sitting is
Because
also valid.
time up.
Yes. To stand.
So while he's standing, then start. As we go, we start time and see how it's going. So you can give instruction, okay, the most preferred side, like front. You prefer the left side, or some may come and prefer to go out on the right side, be the affected or the unaffected. But that could be documented because there will be variation. If one therapist comes and assess through going through around its left side or the affected, then other therapists now maybe do not take that into consideration. You see a variation. And it's allowed also that the patient can use their working aids. If, for example, they're using cane, you can ask them to do it with their cane. Come back and sit with the cane. But it should be documented that the test was using cane.
Enzymas frame too.
Any working device that the patient uses, that you can use it anytime. Not to You can give me instructions. At times, if patient is sitting inward, experience stroke patient, the take time before they can get up standing. But if they are, well, it's just like how do you moderate your patient sitting to sit to stand? If the patient is not like this, you can be able to stand up. But if the patient is sitting inward like this, then you see him even trying before he is able to get up. So maybe the patient is sitting properly, ready for standing. Yes, stand. Yes. Okay, let's. Are you ready? Yes. Okay, 1, 2, go. Nine seconds. 9 seconds. So you can do 3 times, then average will be taken. 09.07.
Are you ready? 1, 2, go.
If the patient comes to sit down, takes him time.
Yeah, that's still part of the part of the time of the test. That's part of the time.
Yes.
Yes.
They are all challenging.
It's still part of the assessment. So that is the test. And there are these tests, like I said, they are subjective, they have some limitations. Some patients, it depends on their impairment. If you ask them to walk slower, it will be difficult for them. All they want is they can quickly go back and sit down.
Yeah.
So you can see it is just a limitation now. Because if you ask them to walk on their comfortable position, they might end up falling down. So if you ask them to walk as fast as you can, they will go and come back and you say they have excellent balance. You say they have excellent dynamic balance. But there could be some problem that they are having. When patients have problem with balance, instead of some, they walk, swaying, showing impairment in the balance. Some will just walk as fast as possible to where they reach.
Yes.
So that's one of the limitations. But like I said, these tests are going a lot. Most of them, they find out okay, there's 1 or 2 limitations, and they're adding it, removing this, changing the scoring, and many things. So there are modifications now. That there's an addition of cognitive tasks. You ask patient, apart from walking and coming back, ask the patient to count, let's say from 80 to 100 backwards. Are you ready? 1, 2, go. But now you tell him that while you are going up, while you are going and coming back, you count from 80 to 100 backwards.
From 100 to 80.
From 100 to 80. No, from 80 to, from 100 to 80, sorry, thank you, from 100 to 80. Okay. Or you can say from 80 to 100. You see first, then you can make it fast. But most of the time, especially for those with cognitive impairment, immediately you introduce a second task, then you find it difficult to do. We have always seen this. You see a stroke patient walking, and you ask him, Baba, good morning, how are you? You stop. Yeah. I'm fine. I'm okay. Then continue working. Because they cannot have those dual tasks together. Because they rely on mental, they rely on cognition contribution for that gift, which ordinarily we are working, we are making phone calls, we are driving, we are doing many things together. Sometimes, unless we are even covered, we will now see how many things we are able to do at the time.
But when there is this problem, especially for stroke patients or with some neurological patients with cognitive impairments or dementias, you see some of this. So they add this task now as the patient count. Are you ready? 1, 2, go. 81, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91. The task is they have to plan on how to do this. They have to count correctly and many other things. So you will see the balance becoming poor if they depend on cognitive contribution. You see it becoming poor. So there is also another modification or addition. Ask them to yes, the manual. You hold a cup of water. Hold a cup of water. Yes. Are you ready? Go 1, 2, 3, go. You hold the cup of water, then go around and sit back. Just feeling the water. That throwing the when they feel it means they are not testing their limits. They are not. Yes, it means they have problem with balance. So these are some of the modifications that are in addition to the type of our test. And scoring, of course, for it. Yes. But I mentioned that it has ceiling effects. All those little balance impairment, it won't be able to detect.
And then even some variations. I've seen a lot of variations. Like some would say that 5 seconds is not 9, 14 seconds, 8 seconds, 9
yes,
seconds.
there are a lot of variation. For the apparently healthy, because of how the data was put. Yes. How the data was put depends on the country or the continents or the regions, then also the population. There are patients, what type of patients? What patients and various kinds, they also have their own variation of scoring.
So it's going to be different for stroke patients for Parkinson's.
Yes. Yes. We all have different score.
So this time of angle, can we say did it fall under screening test or evaluation?
It could be both. Yes. But we can see further modification. If it was initial time of angle, I'll tell you this for screening. For example, I use it for screening on my participant during my program. I only use it for screening because I want to involve them on background working. And I don't use time of angle to see if they're able to do it and go for the background work exercise. But with this modification now, with addition of cognitive tasks, then it's further telling you that there will be cognitive impairment, there will be some other things that are affecting the balance, not just motor aspects, there will be non-motor aspect of impairment. Okay, are you the one that made the comments about the test? Or is it Dr. Jimmy Samani? Okay, so I think Dr. Jimmy Samani. People are saying they could not hear the audio very well.
I mean, since this one was since I think it was.
I'm just checking the comments now.
Yeah, it's okay now. I can hear now. Stopped at the phone.
Let me share this.
Yes.
Somebody is saying, can you recap the TUG cognitive?
Somebody is asking me. Recap the TUG cognition. For the question I just picked now on the comment section, the TUG cognitive is involving some cognitive tasks, counting, calculations, and many others. But one of the standard ways is asking patients to count from 80 to 100. But you can start with forward span, or you can do the backward span. But what is documented is supposed to be the backward span. But I show you, even the apparently healthy, ask them to do the forward span, even the backward span, it will be very difficult. For example, asking patient to stand up, do the test, and start counting from 100, 99, 98, 97, 96, 95, 94, 93, 92, 91, 90, 89, and sitting down. Even for apparently healthy, I show you, they will struggle to do this. So you can do the forward span, then later you can improve it and do the backward span. So let me share the
The last demonstration was for the question Dr. Nasser Hassan asked about recapping TUG cognitive. Okay, now we'll be looking at the trunk assessment. I will also want to revise some things because of participants that were not here in the previous presentation or in the previous workshop. I'll quickly recap through this. We have trunk assessment now. What is this trunk we are talking about all the time? Is the area between the neck and the thigh. That's where we have the pelvis, we have the abdomen and the back or the lower back. We have the chest or the thorax or chest and the upper back. Chest and upper back, or we say the thorax, we say lower back and abdomen, or we say, yes, then we have the pelvis. Yes. There are a lot of muscles that are involved in So this is the part when we talk about trunk, and we have a number of muscles involved that helped in the smooth functioning of the trunk. These muscles are involved in motor function, the movement, coordination, and others. Then we have the sensory function also, which involved especially proprioception, position of sense or posture of the trunk, especially the rotator muscles and so on. Then, not just the trunk muscles, other muscles from the upper limb and from the lower limb also contribute to the function of this trunk. I've talked about also the stability, the proximal stability, the distal stability, mobility on stability, which we are going to demonstrate that. Then I've talked about the various movements. This is key in understanding this assessment that I want to do on trunk. We have the famous flexion extension that we are aware. We forward flex, then we extend backward. We flex laterally, and we flex laterally to the right. We flex laterally to the left. We have axial rotation. That's we have rotation of the trunk. However, we have upper trunk rotation and we have lower trunk rotation. And we have the whole rotation of the trunk. Then we have the same lateral flexion. What I explained is the one we are very familiar with, the upper trunk rotation to the side, or lateral upper trunk rotation, and the lateral trunk upper trunk rotation to the left. Then we have the lower trunk lateral, sorry, I'm talking about flexion. Lateral upper trunk lateral flexion to the right, upper trunk lateral rotation to the left. Then we have lower trunk lateral flexion to the right. We have lower trunk lateral flexion to the left. So we can see the lateral flexion we are used to, we have two. The lateral flexion we have been involving patient all the time is the upper trunk, but we are missing out the lower trunk. So that means we have been missing out in key assessment of trunk that involves especially locomotion. When you assess that lower trunk, you see that the patient will be able to move or not, right? From there, you'll be able to know. And then we have the pelvic rocking and we have the pelvic scooting also, which I will demonstrate this. Trunk is very important in the assessment. I've said it predicts how better it has a prognosis that poor trunk control at admission is associated with longer length of hospital stay. At the beginning, you're able to assess trunk of patients is on admission. You know that it's going to, if he's a poor trunk function or trunk impairment, it's going to stay longer than those with better trunk at admission. So with even better gait pattern and better, longer distance coverage after discharge, and many other things, trunk is associated with yes, there are what is called compensation. If you're assessing trunk, the individual will be having some movement using the lower limb. Okay. So while making assessment, you will know that there is a weakness in that trunk, not just by the posture of the trunk, but when a patient is trying to involve any movement with the trunk, there could be compensation using upper limb and using also lower limb synergistic patterns. So let me demonstrate this movement, then we can pick some of the tests and start looking at them.
So just by patient sitting down, you know that I don't maintain upright position, you know that trunk is just relaxing or putting to one side. When they move, you usually see this synergistic pattern or the compensation using the upper limb or the lower limb. So that's what you observe most of the time in this test. You see how the lower limb is involved in the trunk movement, which is not supposed to come in to assist because the muscles there cannot function as they are supposed to be. Lower limb muscles. So I'll talk about the various movements. We have the flexion, the extension, right? The flexion and the extension. Then we have the rotation. So this is the upper trunk rotation. This is the upper trunk rotation. I'll talk about the mobility on stability. This trunk, upper trunk, is rotating because the lower trunk is stable. If it's weak, the patient will not be able to do it. So that's why you also need to check this mobility and stability. Sometimes you need the stability, all of them, for upper limb function. So most of the time, most of the patients, we do a patient for this week or two with the man there. And one of the things is weakness of the trunk, and the patient could not be able to reach out because of lack of the stability of the upper trunk, lower trunk, going to a good function. So sometimes when managing patient, it's not just go straight to like with upper limb, lower limb, upper limb, lower limb, exercise upper limb, lower limb, and that's the patient to move. This trunk is where this upper limb and lower limb are attached. And when it's weak, you don't expect them to function as they are supposed to. You don't expect to have a good balance. You don't expect to have a good mobility or gait. You don't expect the upper limb to function. Because the upper limb lies on the trunk. If you don't have a very good platform to glide, then you won't be able to see that one as effective as it's supposed to. Sometimes the function is not just on the because of the call it dynamic stability. For the upper limb to function, it needs dynamic stability of the movements of the upper limb. It needs the stability of the trunk. The distal needs the stability of the proximal, and so on. You want to write, you need this, and you need the trunk. So you can see how if the trunk is weak, just simple writing will not be perfect. So rotation of the upper trunk, right? Lateral flexion of the upper trunk to the left, lateral flexion to the right, lateral flexion to the left, lateral flexion to the right. Upper trunk. Then we have the lower trunk. We are flexing it, lower trunk, right? Also flexing. And how do you rotate the lower trunk? By pelvic splitting and rocking. If you understand this, when we go straight to trunk impairment scale, you don't see it as a bonus. Most of the time, we don't understand these movements. That's why the scales we find it very difficult. We're even thinking, what are they even assessing? This movement are straight what they are trying to do. As you see some tests asking patients to turn. It's because they want to see the rotation. Do this, roll. It's this individual movement that they are doing. So you can also make the lower trunk rotation. This is also another way of lower trunk rotation, right? Then the upper trunk also. Then the whole body rotation. So it depends on where you can see how you can break down the trunk and find out which area in particular is having problem. Is it coordination or is it the mobility? Then you begin to treat. Then you now see a better outcome.
So how about the flexion extension for the lower trunk? Can you flexion extend it?
That's what you have the pelvic tilt, which is not they said it's it's a developmental movement in children, and like it's not part of what, but it's also involved in the management of rehabilitation of neuro patients, especially in the Bobart concept. You see this in the parents, you see this all these movements. I think the workshop we had last night, I was trying to explain this movement, and I know it was difficult for some people to grab it. But maybe after this assessment, if you go back to the workshop we did there, I know you were there, you are one of the subjects. You go back to that trunk movement we did, now to make more meaning.
Flexion extension.
Yes.
In the trunk. Yes. Is it not in the lower trunk? Is it not in the upper or the lower?
Yes, this is in the
whole. To me, the whole trunk. Movement is more in the
when you flex and extend, is the whole trunk, but it's occurring at the lower trunk.
Yes.
Yes.
It's like she's asking flexion and extension with lower. How do we do flexion and extension?
So they occur together, the upper and the lower.
Yes, you can do this, which is rotation, which is anterior flexion, pelvic tilt. Yes, then it's flexion and extension too. But you also have the pelvic. So that's why I said, where is the trunk located? That's why I have that first slide.
Yeah.
Where is the trunk? The trunk is from shoulder down to the thigh. The pelvis is part of the trunk. We are not isolating pelvis as another place. Any movement in the pelvis is also part of it. So we are going back to assessments in the still while standing. Yes. Before we go back to the other tests that we do in lying position. So we can look at functional reach test. That's a test to assess limit of stability. Ask patient to stand close to wall, but not leaning on the wall. You have a mark, you can use this. Have a mark around the shoulder of the patient. Ask him to place the shoulder at 90 degrees, standing close to the wall or close to the mark. 90 degrees, standing close to the wall, but not on it. Placing the arm 90 degrees, then asking the patient to reach as far as he or she can.
Affected hand or unaffected hand.
There is also variation. What is okay? We'll talk about the variations or the modifications. Is back balance skill that will tell you to use 2 hands and other tests. But yes, but the functional reach test is just 1 hour.
This
And
is function.
you ask the patient to make a fist. Ask the patient to make a fist. We can start here. Just want to have a marker. I'm taking it step. Yes, I'm taking it step by step.
Yes.
Make him to make it. Ask him to make a fist.
To know the initial.
Yes, to be able to know the initial. So you do the fist that you can be able to do that. You mark the initial using the third metacarpal. The third metacarpal. You mark the initial stance or the initial position. When you reach out as far as you can. When you take the measurement.
This is up to 13 inches.
Okay, do you have marker so that we can take the initial marker and take the measurement? I was most probably. So that's all the safety I was also talk about. We can mark.
Yes. Can we make it make the bigger ones?
Okay.
This is 10.
Okay. So you ask the patient to reach out as far as he or she can. Let's say this is the farthest I can go. We'll take the measurements.
Yes.
30 centimeters. 30 centimeters.
This is 50 and this is 20.
Now, one of you asked the question. You're standing on the unaffected side. Yes.
Okay, standing.
Yes. But you could have patients who are quadriplegic. It's both sides that they are having problem. So there are also some modification on how to go about it. But this is for standing. You reach out as far as the patient can. Then you take the measurement. Then you know that whether the patient is happy support. But he's reaching out forward. Then you stand in front. Because the likelihood is they will go forward, falling down or whichever problem they are in. They are able to hold them safely. Safety is very, very important in all these tests. You want to predict fall, you want to prevent the fall, then we shouldn't have fall. So you assess, you take the measurement and find out how much distance the patient is able to reach out. Then you have the lateral reach. Patient standing, then reach out to the side as much as he or she can. Can do it to both sides and assess. I'll also do it 3 times and take average to get the better reading. So reach out to the side, reach out to the other side. More recent, there is a backward reach. How do you do it?
Extend the shoulder.
Extend the shoulder. Okay, this is how we do the backward reach. Patient is standing, then we lean backward and see how much distance is from the start to where he's able to reach backward. Not.
Can we try to confirm whether it will go the 30 cells?
We can try, let's see.
Is it with this hand?
Yes.
Okay. This is the initial.
No, I have to.
Yes. Okay.
No, it can't be. That's the back which is to reach forward, also backward. Then you can do it also to the side. For those that are not do not stand up.
Possible some extent. Patient cannot even sit strong. Functional assessment is patient, when patient is lying down, you know that there is a problem in that. There is a patient lying down and his scalp one side. It's not symmetrical. You know that there is a problem with that. Even as the line code is lying to fine. You could detect that there is a problem. It means that this assessment code has to be stage by stage. It's not that if the patient, you have to even teach him how to sit up. Yes. You are going to since you see it from the line position of there's a problem with trauma. That will be line in the line of the management and the operation of the assessment. Like right from line, you know that that patient is having some trauma. You don't even have to make why they are lying down, why they are just sitting down. Various causes. Then you now go for that find out trauma the trauma instead of documenting impaired son or weak son tomorrow. Yes, you can do that. You cannot go for that process. For that complete scale. And like I said, some of the skills, for example, they tell you the patient can't do at this level. You can say TIS, right? You can say this work balance scale, this is because I'm not even go for that. Right? You take a break. Based on very, I don't know whether you have done it at work. But there are some terminologies, maybe also from somebody. So the mini picture is for tweets. Many weeks ago, many weeks ago. So somebody was saying that made the debate. So we are next month. I'm here by 9:30. Around 5 waited almost come back by 1:30. 1:30. We take Trump Independence Day. We take Trump Control Test. Take contract execution test.
Thank you, everyone. Let's have breaks. We'll come back by 1:30.
So many technologies about
Mommy, is it sounding like mommy?
Mom. M-N. That means mom is M. Mom is M. What is why they are M-N? Why they are two M? Mommy, I want money. No, I say I want money. You know what I said? You hear what I said?
Good afternoon, everyone. Welcome back for the second session, today's presentation. The practical demonstration of balance assessment. We have started talking about the trunk assessment. We have demonstrated the functional reach test. We have demonstrated the various movements in the trunk. And we'll now start looking at the trunk assessment based on the skills and the tests that are available. We'll look at trunk control test. This test also was discussed extensively last time in the previous workshops. So today we'll be looking at the demonstration. The trunk control test is a 4-item scale, which includes rolling to weak side, rolling to strong side, balance in sitting position, and sitting up from lying down or lying position. All is required is bed or treatment table or Bobart plinth, but we don't have the Bobart plinth here. We'll probably use the mat for the demonstration. So we start with okay, let's start with sitting. Says that the trunk control has is a 4-item scale. Rolling to weak side, rolling to the other side, and then sitting. Rolling to weak side, or rolling to affected side, then rolling to the unaffected side, then balancing sitting position, then sitting up from lying position. Okay, we can start with sitting. As we can.
It's your face. Oh, okay, no, thank you.
So, balance in sitting position. The thigh on the resting on the couch or bed. The feet off the ground. Yes. To ask the patient to sit to maintain the posture. Just to sit. So the overall scoring, because there are 4 items, the highest score is 25. So if you multiply 25 by 4, by the four domains or the 4 skills there, you have the maximum is 20. The least score is 0. So patient will have range of 0 to 100. You say rolling to weak side, rolling to strong side, sitting, then sitting from lying position, sitting down from lying. Those are the 4 skills, right? Then you have the 25. Out of the scoring, you have 0, 12, and 25 as scoring. If the patient is unable to perform the task, 0. Is able to do it with assistance or with support using the hand, upper limb and other things, then it's 12. It's able to do it, complete the task for the specified duration without any support, then it's 25. You can see maximum is 100 or minimum is 0. Okay, for sitting, the patient is able to sit without support, standing erect in a neutral position. Symmetrical, able to maintain this for 30 seconds. It's called 25. The high score for the sit. If unable to do it, he needs hand to support. Then
12. If the patient could not do it up to 30 seconds, once it's up to 30 seconds, then it's called 0. So that's for sitting. Now we have rolling to the weak side or rolling to you can start with rolling to weak side. How the screen is displayed.
The screen is not displayed.
So not rolling, please. I think I'll be talking about something. Rolling to weak side. Patient is lying down. Assuming the weak side is the right side. Then as the patient to roll to the weak side. Initial formation. Supine line. Lower limbs. Yes. Hip and knee flexed. Yes. Then holding the hands together and rolling. Rolling to the weak side. Then rolling to the longer side. So if a patient is able to do it without any support, then it's called 25. But he needs to pull the edge of the bed. Yes. To pull himself. 12. Or you draw the bed sheet. Trying to get yourself or hold anything. Then he's using support. It's called 12. The patient is unable to do it. Then scores 0.
The weight of the affected lower limb would be easy to stand in a position, then with the abductions.
Okay, to hold
most stroke patients, the affected lower limb is to be in this position, then it will just fall.
Yes, they can do it that way, provided they're able to roll.
Okay.
If it doesn't have to be flexed and this position, it will be like this and it's able to roll. Will be in a just regular position and just able to go. You can see here is the whole trunk. It's not upper trunk.
Yes.
So then we have sitting from
You
like
don't have a 17 and 8.
no. It's just 0, 12, and 25. Like I said, some skills they just have the way of doing coming up with their scoring. Some have a very difficult way of scoring, like so many of them. So now we have sitting from lying position. You have roll. Ideally, in some concepts, what is expected when a patient wants to sit is to roll as part of rehabilitation, as part of Robert's concepts. They will roll, then ask the patient to sit. So how is he sitting? He sits normally without any support. Then he's called 25. But he needs to hold the harness or needs to hold something to pull himself up. Then it's called 12. Then he will not do it at all. Will not get up. Then that's it. But he's able to stand up. There's no problem. It's called 25. It's called only 25 for that's why we have hundreds. Four of them, then 0 as the minimum. So we can now look at the more extensive test, which is from the scale. So some contrast test, 100 years and 0 is the minimum. We have 50 or less indicates poor recovery or impairment of trunk. Less than 50 would be a problem. So we can look at trunk impairment. We are talking all about the psychometric properties and just to demonstrate how to administer it. The starting position, all of in the trunk impairment scale is sitting, all of sitting. The patient will sit. Here is a copy of the trunk impairment scale. You can look at it. So the patient is sitting on the edge of the bed without support at the back as usual, at the other breast. Thigh supported by the couch, the knee and hip 90 degrees, arms on the legs, right? So, if the patient is having spasticity, hypertonia, and could not sit, because it's supposed to be in a neutral position, the head aligned with the spine, but because of hypertonia, is not symmetrical. Just take that as the starting position. So there's nothing you can do about it. That's how you can best assess. So, like I said, if some test at the beginning or at some stage, patients score 0, they will tell you not even proceed to another one. So it's like in a stage or in a sequence, this particular trunk impairment scale. Unlike the trunk control tests that are independent tests, but this one, they depend on each other almost all through. So if the patient cannot do the first one, then don't bother going to the next one. It's called 0 in everything. So there are items. This prescoring is 0, 1, 2. Patient cannot perform completely, is 0. Patient can perform partially, it's 1. Patient can perform fully, whatever it is assigned to do, without compensation. There are definition of each of the compensation for each of the assessment, which we are going to see. I mentioned it at the beginning during the discussion of or introduction of the trunk assessment. We see that when there is weakness or when there is hypertonia, we see compensation using the upper limb or the lower limb. So this kind of assessment is applied in impairment scale because some of the scoring are to observe compensation. Some are to observe the mobility or let's say the muscle strength and other things. So there's no practice session. Not that you allow the patient to practice and not score it. If the patient does it, you score it. Unless that you can say, okay, you can take the better, maybe it's scored 1 here and it's scored 2 here. You can pick up the better score, but there is no practice session. So you can give some verbal cues on how to do it better. It is okay. You can demonstrate, which is also okay. So there are 3 domains: static sitting, then dynamic sitting, then coordination. So we'll start with static sitting. And sorry, except for the first item and I think the second item, they do follow that exact scoring 0, 1, 2. One has 0, 1, and the other one has 0 and 2. So you see here, item 1, we have the static sitting balance. The patient is asked to sit, just normal sitting like we did in the trunk control test. Patient just to sit. So without support anywhere, she's able to maintain the sitting for 10 seconds. It's not able to maintain it for 10 seconds, it's falling, it's using hand to support it, then 0. It's able to do it for 10 seconds with eyes closed, then that's for 1. So you can see the cell, if patient scores 0, the whole everything. If patient can't do this, then what do you expect the patient to do? Can't do anything again. So just stop there. Patient,
Yeah.
you remember your question. So everything stops here. You don't proceed. So item 2, if it's able to score 1, then you cross to, you can see the other one is 1 and 0. Then you see here is 2 and 0. So these are the only 2 out of the whole scoring that you don't follow that 0, 1, 2. And you could see it also on the paper there. So the first instruction is the therapist should lift the patient's unaffected limb and cross it over the hemiplegic. By this, you are causing problem for the balance. Then the patient will fall or be looking for where to how to stabilize inside. So patient cannot or fall within 10 seconds. That's 0. Patient can maintain sitting position for 10 seconds. And then scores 2. Understand? It's clear, right? Yes. So let's see item 3. Then item 3, patient crosses by himself. Item 2 is the therapist that will cross the lower limb or the unaffected lower limb over the hemiplegic or the affected. Because this scale is developed solely for, it was developed for stroke patients. So that's why you see the instruction. They are for stroke patients. They are saying him straight. So no any other thing. And like I said during the presentation, it was the supervisor of Heidi that developed this history. We check, you see the if you see the publication there, you see the name of the therapist. Yes, provided the introduction. So you cross the patient crosses the unaffected limb over the hemiplegic. So if patient falls, remember the first one, the therapist does it. Now is one doing it. So if you can see, if you cannot do that first one, it cannot come to it. So this one they are like sequential. All like other tests that this all other items are independent. So the patient crosses by himself. So if he falls, that's it. Patient cannot maybe we'll start from the highest. Patient crosses the legs without trunk displacement. It means he has not done any compensation. He has not done this. Cross it. Or is 2 if patient crosses the leg or displaces the trunk no more than 10 centimeters. So not too much of displacement, but if able to do it. But this one, the displacement is not, there is no displacement at 3. It's able to do it. But this one, displacement is not too much. But 1, patient cannot cross the legs without arm support. You need to cross it. Any other thing, sorry, he's doing it by himself. Yes. Actively, not lifting the lower. He's not supposed to cross it. But this time around, he's using support on the table to fix himself, to make him stabilize on the bed. Then the third one is while trying to do it in output, he's unable to do it and he falls. Then that's for item 3. Then item 4, dynamic sitting. Patient is instructed to touch the bed or table with the hemiplegic elbow. Let's say this is a hemiplegic elbow, then you do this. Do you remember the lateral flexion I mentioned? So this is it. So what you do here overall now is to check whether it's able to go and touch, whether it is able to touch the elbow or not. You understand? Yes. So let's see this column. Let me read down this column. See next slide. Yes. Patient falls while trying to reach. That's 0. or is unable to touch the bed, it still scores 0. Then patient moves actively without help and touches the bed, then that's 1. You understand? So if you score 0, then don't bother going to item 2 and 3 of the dynamic system. So they say if score 0, then items 2 and 3 scores 0. Because they are the same things. They will ask you to repeat it, yes, but what you observe are different. You understand? So if it's able to do it, so now in the item 2, it's a repetition of item 1. Now we are not checking whether it's able to reach the elbow or not. You are checking another thing. First of all, you check whether it's able to shorten the affected side that is going towards. You understand? Mm-hmm. So a patient demonstrates appropriate shortening and lengthening. What they mean is the side you are going towards is shortening, and the opposite side is lengthening. I mentioned it last time during the presentation, and I remember somebody asked a question. Because I said when a patient has stroke, you are not looking at only that first side. It's a bilateral thing, and the lady asked me that she thought stroke is only one side, and I'm now saying it's bilateral. I said no. When there's shortening of this side, when there's movement of this side, then definitely the function of the opposite side will be affected. Mm-hmm. If the patient has been on the flex posture for a very long time, this place will be contracted on the lending position. If this place is contracted, contractual on the shorting position, this will have contractual on the lending position. Then you have to do the works. Not just this side, you also have work on the other side. So that's what it means. What you are checking now is not able to reach the elbow. Yes, it's able to reach it and so on, but is there appropriate shortening? Because as I'm doing this, there's shortening of the side and there's lengthening of the side. What happens if you cannot do it? You'll be making compensation. Because you cannot lengthen this side and you cannot shorten it appropriately. That's item 2. It's a repetition of item 1, but another observation different from the first one. So now the item 3, you repeat item 1 again, the same thing, but now you check for compensation. And I've mentioned right from the beginning while I was talking about trunk movement. So if the trunk is having there's hypotonia, there's hypotonia, there's impairment, you will see compensation. And compensation is use of upper extremity for them to be able to reach, to go something to be able to reach, or to be able to do to affect the shortening and the lengthening, or contralateral hip abduction. And as I was demonstrating earlier, you see hip abduction, you see knee extension. That's what you usually see on the patient doing, because they cannot move the trunk. They cannot do those isolated trunk movements that you want, which I described: the flexion, extension, and the lateral flexion, the rotation, and so on. So, or sliding of the feet. If the feet is on the ground, you just give slide using other body parts instead of the trunk. The patient scores 1 when there is no compensation. When there's compensation, the patient scores 0. Okay. Item 4. Patient is instructed to touch the bed or table with one affected elbow. What we did was with the affected elbow. Now it's unaffected side. Let's take the unaffected side. So we also observe that shortening and lengthening, and how you return back, returning also back to the starting position. Yeah. So patient falls, needs support from the upper extremity to be able to reach out. And that's the patient moves without help, just to reach the elbow. That's 1. Couldn't do it, needs support. Other upper extremity, using the patient pushing himself and using all sorts of support to reach to that movement, to that flexion. Then it's 0. Then we go to item 5.
So item 5, the same thing as we did for the affected side. We check for appropriate shortening and lengthening. When you do this, is there appropriate shortening of the unaffected side? Is there appropriate lengthening of the affected side? You remember during our PNF concept, we talk about eccentric and eccentric work of the muscles. These are the things that we miss out a lot in the application. So now you can see, we talk about shortening of the muscles, then we talk about the lengthening. Here I also talk about the shortening and I also talk about the lengthening. These are key things in the management of the application. So now look at the next item.
How can we have an opposite shortening on it?
How
can we have the opposite shortening on it?
Okay. When you do this, when you reach out with the unaffected, this is now the unaffected side, your elbow reaching out on unaffected side. You are supposed to have lengthening of this side and shortening of this side. When you do this, you are supposed to have shortening of this side and lengthening of this side. So the same muscles here, we talk about lengthening. The same muscle here, we talk about shortening. The same muscle here is now turned into lengthening. And we talk here now turned into shortening.
It's for the 0. When patients demonstrate no or opposite shortening when I'm
yes, when you could not shorten it, we are not checking whether the elbow now is the elbow we have checked, yes, but now we are checking whether there is shortening. If you could not shorten it, is now using upper limb to pull himself and trying to do it, not the appropriate muscle contraction to shorten and to lengthen this side, then it's 0. Yes. Then item 6 now, we are now looking for compensation using the upper limb, using the hip rotation, the knee flexion. I will talk about the sliding on the floor of the feet. Item 7. Patient is instructed to lift pelvis from the table. I'll talk about this in but I've been able to do it at the hemiplegic side by shortening on the hemiplegic side and lengthening of the unaffected side.
Flexion. Flexion, if the elbow touches the bed or table further than the body will have. Item 6.
Okay.
When the hip flexion, if the elbow touches the bed or table further than proximal half of the
okay, hip flexion is compensation. You look at whether the person involves upper limb or the contralateral hip will be abducted, and there will be knee flexion, right? Or sliding of the other foot there on the ground.
Yes.
Will be slided. Will be sliding. Yes. Yes, if it's able to lift pelvis, then you look for appropriate shortening or appropriate landing on the opposite side. Then item 7, okay, that's the scoring. If score 0 for this, then for the next item 8, score 0, automatically go to the next item. So let's see the 8. They are the same thing. Repeat 7 is to repeat 7 and check for compensation. Then next one, 9. Patient is instructed to lift pelvis from table or bed at the unaffected side, now the opposite side. You see patient unable to do this, he asks them to update. You see a lot of them. So he asks them to do this and check for the shortening and the lengthening. Shortening on the side you are contracting and lengthening on the opposite side. Then the next one is compensation. You also check. You repeat and check for next one. And repeat and check for compensation. That's 10. Which is clear now. I think I don't want to be, I don't have to be explaining them because I believe they are now clear. Then check for trunk coordination. Patient is instructed to rotate upper trunk 6 times. 1, 2, 3, 4, 5, 6. So each side should move 3 times, but you start with the hemiplegic side. This is the affected side. You start with 2, 3, 4, 5, 6. But the head should not be going along with the scapula or along with the upper trunk activity. It should just be fixed. 1, 2, 3, 4, 5, 6. 3 each, starting with the affected side. So the scoring is for individual to be able to let's see this for individual to be able to rotate. If cannot move 3 times up to 3 times, then that's 0. 1 is if the rotation is asymmetrical, is rotating, but this one is going further, then it's possible stop. So that's 1. Then rotation is symmetrical. It's able to do it symmetrical, and that's 2. So if score is 0, don't bother to go to item 2 because it's anything. What I'm going to do is now with more difficult 6 seconds. I'm going to repeat it. 1, 2, 3. You should be able to do it within 6 seconds. If it's 2 seconds, 3 seconds, I'm able to do it, but you shouldn't go beyond 6 seconds. Then if they are unable to, if the rotation or unable to do it, or rotation is asymmetrical or whatever it is 0. Rotation is symmetrical, then 1. Then lower trunk, rotation 6 times. Okay. So first with the hemiplegic side, just like the upper trunk. Upper trunk is fixated. So every knee should be moved also 3 times. Then I can, still on item. This is the scoring. Hemiplegic side should if they are unable to do it 3 times, especially the hemiplegic side unable to do it 3 times, then that's 0. Just like the other one, the rotation is symmetrical 1. Sorry, it's asymmetrical 1. Rotation is symmetrical 2. If score is 0, then don't bother go to item 4. Just give it 0. So item 4, repeat it just like 6 seconds, just like on the upper trunk. 1, 2, 3, 4, 5, 6 seconds. If it's symmetrical, 1. If it's asymmetrical, 0. So overall score is 23. The minimum score is 0 for trunk impairment scale. So this is trunk impairment scale. If you want to demonstrate or yes. Plus, so you can see that's why I introduced those movements before we started trunk, any of the trunk assessment, because now I have to start explaining this. If you get those movements at the beginning, that's one. And even when you come to your management, if you target management of trunk for these movements, this coordination, you're already managing trunk impairment. That's one of the things. The assessment are also different.
I want to know for which domain, before domain, are we going to use the other?
What they said at the beginning, just for sitting, the patient scored 0. It means he cannot do all these things we have mentioned. The whole scale is 0. If the patient cannot just sit for 10 seconds, what do you expect the patient to do? He cannot do anything. You don't expect the patient to do anything. Talk of lateral flexion, take it of lifting the pelvis or crossing the lower limb and all those things. Patient can, just to sit for 10 seconds, not do everything's goes down to 0 and you just close the scale already. Maybe look for something else to check. Maybe some controls scale. Maybe since it's much easier. Or the function in sitting test and many of them. Maybe we'll talk about function in sitting test, then back balance. Impairment. Yes, I've just mentioned this in a bit. Although this workshop is for assessment, but sometimes I think my previous work, I also talk a lot about analysis. I said now, if you're able to go, maybe I want to find out where the target is. If you're not able to reach, you're not able to go so fast, reflection, you're not able to rotate the upper, you're not able to rotate the lower trunk. Where is the problem? You not target it, and you manage it, then you see the improvements. One of the things is that there are lots of facilitation that you can do to do those things. I can demonstrate some things. You can sit down. These are, although there's going to be a global concept workshop, I believe, along the calendar, but we can see something. For example, patients have a problem with lifting the lower trunk. You facilitate and help. Passively for active assistance, or you can even give resistance. So that's just one way, for example. When you look at it, you say, but you see it as simple as it is. So this is just one way, for example, is able to. So for the part of two, how you can facilitate various solutions, how you can facilitate various flexion, side flexion, all those things. So do you want to demonstrate? Yeah. Yes. Item 1, proper sitting. Yeah. It has the static sitting, that's the dynamic sitting, it has the deflation. Yes. They are taking static sitting. Just able to sit for 10 seconds. Yes. Moving the eyes, yes. People able to do sit for 10 seconds and 0. They're able to reach 10 seconds. Yeah. We'll see that for trunk control test, they say up to 30 seconds. But for trunk impairment scale, 10 seconds. Closing eyes. The static sitting. The next item is the cross. Okay, assuming this is the one is cross. Yes. The unaffected over the affected. So if you're able to maintain the balance, you're able to maintain the posture, then you're able to hand position. Just not to give support. That is all this. Then the next thing is you will now the unaffected, the affected. No, the unaffected.
You did it yourself.
Then the dynamic sitting. Okay. What should we have collapsed into the okay.
Don't rotate back.
Because that's one thing you just notice that the patient just throw himself into the bed and on the elbow, or he gradually contracted the muscle to reach the bed, or he just feel that okay, it's a soft bed, let me just go down and just fall on it. It's possible because that's what I say. Whether the patient falls, you can see the instruction. The patient falls on the bed, or yes, patient falls on this support. That's the falling. You just collapse yourself. But you are supposed to gradually create a muscle contraction to be able to reach. Maybe you have crossed the arm too much. Yes. This is
Okay.
They can see contract instead of lengthening. Yeah, because maybe this muscle is short. Because because it's supposed to give way for the side to contract. It's supposed to lengthen. It's supposed to contract eccentrically.
Can you separate them? This one remains maybe on the.
Yes, all we want is for the elbow to be able to reach. Yes, that's what we need. Yes.
And I think it's
then we have, because it's both contraction of the muscle. So when we look at stroke patient as just only one side, we have missed out a lot of
strong positions.
Because this one is going eccentrically as it's lending, and this one is going concentrically. Go the other way, this one is going concentrically, and the other one is contracting eccentrically. Yeah. So in both their management, that's why management of a muscle or muscle impairment, it doesn't just come with the concentric that we do. We keep the weight slowly contracting concentrically. But how is it contracting eccentrically is where we don't give much attention to muscle. So then repeat item 1. And again, we check for compensation, whether using the upper limb or using the yes, all the contractions. Yes, the compensations. Then it's smooth.
If I say I'll not move my lower limbs, is it possible?
Because you are contracting not
So my balance need to be checked.
Yes.
No, maybe there is a statistic pattern of movement. It's not like then yes, this is the going to unaffected side. Then you repeat the item, you check whether there is lengthening or shortening. Yes. Then item 4 is repeated to check for compensation. Then lifting the pelvis. It's not lifting the knee or lifting the lower leg. You are lifting the pelvis. It's like you ask the patient to lift the buttocks, not this.
Someone wants a question. He raised his hand. He raised his hand. It's Mubarak, you can ask the question.
Okay. Hello, can you hear me, sir?
Yes.
Can you hear me, sir?
Yes, we can hear you.
Okay. Thank you so much for the elaborate presentation, sir. What I would like to ask is regarding the trunk impairment scale. So the positioning of the foot, is it okay for it to be dangling out of the bed, or it has to be on the grounded on a surface? Because from the way I can see the practice, I think it's going to be very difficult for someone to control the involvement of the lower limb if they are dangling off the bed. So I don't know if it's okay, or if there are better ways. I need more light on it. Thank you, sir.
For anything that can allow for the lower limb to have contact on the floor.
Yes, sir.
And it's one of the qualifications to understand. You could see the subject here as he was making the demonstration is using the lower limb, but I tried to show him that this could be done even as the foot is free in the air. I was able to demonstrate the movement without involving the lower limb. I think I've been using this for maybe 10, 12 years. I've been doing this, so I think yes, using the managing stroke using this trunk movement. So I think it's okay if I'm able to do it, and it's okay if he's not able to understand it at this stage. Maybe this way. Yes, it's possible. Okay, then coordination. Rotation of the upper trunk 6 times. You start with you start with the affection. You are using okay. You're still using movement. No, you can sit down. I think it's better. Right? It is much better now. You can rotate now. But to some extent, you are still moving. Yes. So do it 6 times. Then the other item that comes, you should be able to do it within 6 seconds. So if it's symmetrical or asymmetrical, it's called 0 or 1. Then the lower trunk. Move forward. It's not like you are moving. You are just moving the knee forward, and just like what you did for the upper trunk.
Danny.
Then that is the trunk internecine. So we'll look at which one you need. Function in sitting test, fist. Then the back balance scale have almost everything. That's why I leave it for the last. It has functional test. It has assessment in line. It has assessment in line. It has so many other things. So that's why I leave it for last. I combine everything. So we look at the fist. So now we're looking at the function in sitting test fist. It is a 14 item scale. When you for those that are having the hard copy here with you, it's also a short test, but up to 15 minutes, which makes it, we can't say it's short because we have tests that we can do in 5, 10 seconds, 15 seconds. So 15 minutes is an extended time. So all you need is bed, stopwatch, and there's no any training required to do it. So these are the items. We have anterior notch, posterior notch, we have the lateral notch, and we have the static sitting. We have the sitting in which you ask the patient to shake his head, no, like saying no. or facing towards right and facing towards the left. Then sitting with eyes closed for 30 seconds, sitting to lift the foot, the dominant side, lift it for about an inch or so, then picking object from behind, then forward reach, lateral reach, then picking up object from the floor. Posterior squatting, anterior squatting, like what we do now, then lateral squat. These are the 14 items. I think it's not too difficult, it's not too confusing. So the procedure is, it is from the name. From the name, you know that it is conducted in a sitting function, in sitting test. Yes, you see it has 14 items. So it's conducted in a sitting position. So individual seated at the edge of the bed. Hands are placed in the lap, or less when there are some instructions that you have to place them up or place them somewhere. Then you have to place them. So half of the thighs supported, the hips and knees at 90 degrees. Then we have the, we have it this flat and support. Yes. So you have one trial which will not be recorded. You can give instruction or direction. You can also demonstrate the patient. So the scoring is from 0 to 4. 0 is patient is unable to complete the task. So patient complete the task independently and successfully. 4. Is unable to do it, that you need cues. You have to give him some direction, touch and correct him and so on. Then that's it. You need upper extremity support to complete the task. Then it's 2. Then need assistance. Then that's 1. That's unable to complete. Then complete assistance to do everything. Then that's 0. He's unable to complete it by himself. Everything else is 0. So the first one, there are some variations. Let me just make this point. There are some variations. If you check some literature, you will see these first 3 items. This nudge, anterior, posterior, and lateral nudge. In some literature, you won't see them. But if you include them and make your calculation of scoring, you have 56. But when you look at the scoring, that's why sometimes people remove it. When you look at the scoring 0 to 4, this nudge will not fit. When you place anterior nudging or lateral or posterior, do you say it's able to complete with support or that support? That's why some people discard it. They don't even score it. You can assess whether it has whether the patient has a good reactive balance, to assess the active balance. So that's all. So you remove 4. You remove 12 out of 56. You are left with after 26. That's it. You remove 12 out of 56. 40. So that's what you are left with. That's usually what we use because those things are just more reactive. So you have the anterior notch, give at the sternum, like what we did during the lumbar test. We just give anterior notch. But these are things that the patient, you just take the patient, you just take the patient unaware. As you're just talking, you're just gisting and you just based on perturbations and see how the patient reacts. Then you can do also posteriorly at the parapolas, yes, at the back. And also give this notch and also give lateral to the yes. Then you now check to see how the patient reacts. You just pause
means they have poor reactive balance. So it's able to restore back this position, this or our position. So the first item, proper. Or that's if we discard this thing, then we have static sitting. Just ask patient to sit as I'm just sitting down for 30 seconds. It's able to do it, you score him from that 0 to 4. So the next one is sitting. You ask the patient to shake. No. You're not saying no. Whether that will distort the balance or you able to do it, or you need support and all that. Then sitting with eyes closed now. Ask the patient to close his eyes or her eyes and sit. Then you see whether he's able to complete that within 30 seconds of his falling, or he needs support to stay, or he needs the hands to keep it, and so on. No scoring. Then sitting, lift foot, dominant side up, just 1 inch. Lift it twice. So that's going to distort the balance. Yes. They also check and score. So ask the patient to pick up objects from behind. Sometimes you can just ask the patient to just, when you place something, just sitting down, place something on the chair, just pick it up. You see, talk about rotation. You're trying to access rotation. Pick up something and turn it back. So that is the instruction. Pick up object from behind. Object at midline. Hands breadth posterior. You can see object is at the midline. You just do the length so that you can rotate and pick it up. So you now have forward reach. I said some of these tests you see them with this combination of these tests. That's why we have this individual before coming. So use dominant arm to reach, but you are in sitting position. You are in a chair or in a couch. This around it is not functional reach in the standing position. This around you are sitting, then you reach out. Then lateral reach. But they say clear opposite ischial to velocity. It means it must have lift. You are reaching. So you now see what this movement will now be making while you are making the assessment. Then pick object from the floor, just between the feet. I think there is a certain distance, not just more than a few centimeters. Something we placed, and ask the patient to lift it from the floor. So that is the last. Okay, yeah, sorry. Posterior scooting and anterior scooting. Yes. Then lateral scooting. Move laterally. You have scooted back and forward. Now to the side. Just 2 inches. It's not too much as I'm doing. It's just a little movement you're able to do. And that's about the fist. Yes. Like I said, overall is 56. So if we remove those 3, you have to remove 4. And yes, you have 0 to 1, 2, 1, 2, 4, 4. Then the other item will look like back balancing. So the back balance scale is a 14-item scale.
like I said, it has combined a lot of these tests together. See, sitting to standing, standing unsupported, standing to sitting, transverse, standing with eyes closed, standing with feet together, reaching forward with outstretched arm, retrieving object from the floor, turning to look behind, turning 360 degrees, placing alternate foot on the stool, standing on one foot in front, standing on one foot. So those are it is a 14 item scale, like I said. The scoring is 0 to 4. So you don't have your scale now. You can answer your question. They have low risk, medium risk, and high risk. This is there are already making. So you can make your own application. For example, you have 100%. You can see 25, 0 to 25. But you have to validate it. But this one is already validated based on this. 45 from 41 to 56, low risk, 21 to 40, medium risk, and 0 to 20 high risk. So anything less than 45, anything less than 45 downwards. So what you need is maybe a tape or this improvisation we did for the functional research. A chair with one arm, a chair with armrest and a chair without armrest for the transfer. Then footstool for the stepping, then stopwatch for timing in some cases, then 15 feet walkway that you need to walk. So sitting to standing. That's question 2. Sitting to standing. You are not sitting down. Stand. As simple as that. Able to stand without using hands, stabilize independently. That's simple. Without any problem. Able to stand independently using hands. With his hand, but is able to do it. And that would be 3. But patient is trying several times. That would be 2. Then minimum able to stand or stabilize, or moderate or maximum assistance to stand. The patient has made all the attempts and stand up, but he cannot even maintain the posture, the standing. He has to be give some assistance, minimal at 1 and moderate or maximum at 0. Yes. Then standing unsupported, just asking the patient to stand. Able to stand for 2 minutes, just like the lumbar test. Now I've said the lumbar, the back balance scale is just, if you know those individual ones, then if you have done the screening that we are said in the beginning, then you want to dig further and find out, is it from sitting, standing, is this trunk rotation, which of these skills, which of these domains that problem, you can go further. You want to do research or you want to do extensive rehabilitation on the patient. So, able to stand 2 minutes without supervision. So, able to stand 2 minutes without supervision, that is 3. So, that's 4. Able to do everything, stand safely, no any problem, and that's 4. Then 3, able to stand with supervision. You are
trying to give support to the patient, you feel like going to program. 2, able to stand 30 seconds unsupported. The maximum the patient can go is 30 seconds. It's now showing stepping out or showing signs of lack of balance. 1, this several tries to stand 30 seconds unsupported. You have to attempt it several times. Then 0, unable to stand 30 seconds unsupported. Then sitting with back unsupported, but feet supported on the floor was 2. Sit down without support. The patient is not resting. So able to do it without folding. Able to do it for 2 minutes. Able to sit 2 minutes under supervision, just like standing. Able to sit. That would be 2. 1, able to sit for 10 seconds. 0, unable to sit up to without support for 10 seconds. Then that would be 0. Standing to sitting. Patient is standing, asking to sit. Patient asking to sit. You sit safely with minimal use of hands. Like no need to raise your hand, you just sit like that. Then stop. Then 3, you need some support on the hand. Then 2, use back of the legs against the chair. If the chair is not on the wall, end of the ground, falling down. So use it to control the. Then 1 independently or has control or has just uncontrolled distance. Then 0 needs assistant to sit. You have to hold it back to sit. It will not be. Then transfers. As subject to transfer, 1 way toward a seat with armrest, 1 way toward a seat without armrest. We also use 2 chairs. Just like this. Okay. Now, I have to bring another. Transferring. This one is transferring with armrest. Arrange chairs to avoid transfer. Ask subject to transfer 1 way toward a seat with armrest. It is a seat with armrest. Sometimes you can use couch and chair. So couch with so the couch will serve as a seat without armrest. Then towards the seat without armrest. So, like I said, you may use the bed and a chair with armrest. So able to transfer, because as you have that armrest, the patient will try to use it. I will tempted to use it. So transfer with minor use of the hand, because you don't have to go and grab the armrest and sit down. So able to transfer safely. There's the hand is a bit much more usage, unlike the 4 will be without hand or with just minimum, but 3 is with much. But 2, you have to talk to the patient following the instruction. You cannot do it even with touching with you need more support to tell him or her how to transfer. Then
The other one is you need a therapist to transfer the patient from your to the seat. With less impairment, one therapist can transfer. But with much more impairment, you need two people holding from one side to the other, moving the patient up. So that would be zero. So standing unsupported with eyes closed, the patient will stand. Then this time around with eyes closed for 10 seconds. Able to do it for 10 seconds, there is no problem. Unable to do it for 10 seconds, that would be 3. If you're just able to withstand 3 seconds, and that would be 2. Then unable to keep eyes closed for that 3 seconds. You wanted to do the 3 seconds, but you have to use the visual to watch that it's not going to come back. Close it and it's going to come back. Or then 0 needs help. Need to stand the patient, need to hold the patient. And that's 0. Then standing unsupported, speak together. The other ones, the base of support is a bit wider. But now it's trying to make the base of support narrower, which will make the patient stable. So just stand and able to place feet together independently and stand 1 minute safely. Unable to do it for 1 minute, or is able to do it for 1 minute, but with supervision, we have to stand by and try to hold the patient so that it's not supervising. It's wobbly, sweet, it's very sweet. We have to stop. 3, sorry. Then 2 is unable to stand for 30 seconds. Then 1 needs help to attend position, but able to stand for 10 seconds. Then unable to hold position for 2 seconds completely, and that's 0. Obviously, you want to sorry. This one is fingertips, they said. You can see variation now. So the real functional reach test, they said, is the third metacarpal head you use to assess. But this one, they said, use the fingertips. Yes. So these are the scoring. You have up to scored with up to 25 cm, then scored 4. Scoring up to 12, that's less than 25. From 12 upwards, less than 25, then there's that's scoring 3. Then you have 2, which is 5 cm. I think the morning was what was my score? 15? No, I was up to 30. CM? Yes. 30. From this, so 50 to 20. 30 cm. Okay. When I went back, I was thinking that maybe I have limited reaching, because most of the time when patients have limited reaching, they step out or they fall down or they rotate. I think you are talking about rotation. I remember, I couldn't remember just until now when we come back. There's some they use rotation to compensate. So you look at it like they're able to reach to a certain distance, but they are rotating the trunk. And they're also compensating from the upper limb too. It's not the actual reaching that they do through the anterior.
But if they use the hands, it's going to counteract that.
Yes, when they use 2 hands, they're going to counteract the rotation. Yes. So picking up object from the floor from a standing position. So you have an item just like what we did in the functional function in sitting test, the first. But that one is just in sitting. But this time around is in standing. You have an object in front, and the patient will now pick it up. So able to pick.
They fall down, but unable to pick, but able to reach, but not able to reach that particular end. But when you reach further, then the balance is still both the reach, patient can do it. We're able to pick is zero. So trying to leave behind over the left and right shoulder. Patient is standing. Right. Then see there's right. And from both sides and wish you when you look that behind one side, but that side shoulders, just like in the front of the able to take not through the affected side. And able to do it, unable to do it. Then turning 360 in a full cycle. Turn 360. Able to turn 360 safely, 4 seconds. Now, we are out. Able to turn 360 safely on one side, but it's supposed to be down to right side, go to the right side. So that is the able to count 360 degrees one side only for or less. So able to count 360 degrees one is close to over. Or you know the driving right so that cover the assistant. This attendance boost. More times. That's it. No. Yes. I think that's a question. So, so, it would be 8 times. 4 times 6. Then it would be 8 times 27. That's 4. This assistant for every degree is not every degree. That is zero.
So standing unsupported 1 foot in front. Yes. I think there is type of lesson. You know, I was able to do the tandem stand in the morning, but this time around, only I should try my right. It's still there. It's still working. So that is the last item. Oh, sorry, second to last. Then standing on one leg, and then we have the one leg stance. That is the 14th. We say there are 14 items. So we can see it has combined one leg stance, it has combined rotation of trunk errors, it has combined functional risk tests, it has combined transfer of various step tests and many other tests. So that's why we have those. That's why I said I will leave back balance scale as the last item before we look at them. So that's the last item, standing on one leg. Able to hold it independently for greater than 10 seconds, above 10 seconds, that's 4. Unable to do it completely, then that's 0. In between, we have 5 to 10 seconds, we have up to 3 seconds, and less than 3 seconds. Unable to do it. Then that's the last item. Yes. So we said the overall scoring is we have 56. The risk score is 0 to 20. High for risk, high risk of fall, 0 to 20. 21 to 40, you have medium risk. You have 41 to 56, you have low risk. We have 4 times 14.
Yes.
6.
Yes. It's 56.
So that's the balance scale. So, maybe any question? Contribution. At least almost everybody has contributed to some questions, clarification, and The original one that Professor Mani did last time, which we were able to look at tower scale, then the postural assessment scale. We did this also pass. Then activity specific balance confidence scale, ABC. Then I talk about the best also brief, which I said is a very complex one. Let's look at all the systems in the assessment, find out where the problem lies in the system. Is there any contribution? So over to you, Dr. Jibril Samani. Did you respond?
No, he didn't.
I've said that if a patient is unable to lift, you can facilitate. Some of them, even though we're not using the cost, I mean, the option is not based on treatment, but I've demonstrated that this is one of the ways. It depends on the level of the impairment. And if the buttocks, you can go at the waist, you can do that. If it's the opposite side, you do also the same. So this for the yes, for lifting of the pelvis, right? Yes. So what about trunk rotation, upper trunk rotation? You can do it passively. I mean, active assisted, asking to give the instructions for you to understand this how you're going to rotate. So you can rotate it. You can do it active assisted. You can also give resistance. That's for the upper trunk. The lower trunk too, you can also facilitate the scooting forward or backward.
But sir, is this really being done in the clinic?
This is because I've already said that these are some aspects of Howard concept. I'm trying to demonstrate.
No, sir, in the clinic, do you really do it?
I do it when I have stroke patients. I do this. Some patients, most of the time, they're telling me that they have never done this thing for them.
Yes, sir, because really it's uncomfortable. It's
What?
It's uncomfortable.
No, but you have to explain to the patient. You explain to them, they understand this is the movement, this is what you want to do. You explain everything. Yes, I understand what you mean. It's a very sensitive body area, and you use your hands and all those things. But when you explain why you are doing it,
especially when you are facilitating the
scooting. Yes, you can do to the lower. You don't have to reach to the pelvis. You don't have to reach to the buttocks. You can do it at the upper level. I know. Yeah, it's not the buttocks I'm holding to do the facilitation. It's just the trunk.
Okay.
Yeah. But sometimes you might require lifting the buttocks in some. It depends on the weakness of the patient. But everything has to do with understanding the explain to the patient. They understand the procedure, and they also understand what you want to do, understand the benefits.
So when you are lifting the pelvis up, that is going to be is it going to be like lateral flexion for the lower trunk?
Yes.
Yes.
Yes. The pelvis, yes. The lateral, the lower.
No, lifting the pelvis. Yes.
This is all of the contract.
No, because it's going to be lateral flexion of the lower trunk, right? Yes. Not rotation. The scooting is the rotation.
Yes. No, what I did here is the lateral flexion.
Yes.
Trunk.
Yes.
But what I'm doing here is
rotation.
Yes, it's the lower trunk rotation. I demonstrated upper trunk rotation. Then I demonstrated the lower trunk rotation. This is going to be the upper trunk. Then upper trunk. Then lower trunk. I think I've shown you.
Yes. Yes.
Facilitation of trunk. Almost every angle of it in a short while.
Exactly.
Yes.
Yes. That's for the upper trunk. And then the lifting of the pelvis is for the lower trunk.
Then the rotation. Then the upper trunk rotation. And facilitate all the two. The stroke are missing out in the trunk section and the trunk section.
Exactly.
They're missing out. So when we did this, I couldn't understand all this is much later when you go deeper into the course. That's when, but over years of teaching, I know maybe it's easily how to show this thing and people to understand. But when we had the course, it was a long time, and they couldn't be able to teach us that easy as possible. Thank you very much. Thank you. It's always the issue of time. Issue of patients' workload. Yes. Workload, time, printing the document to keep them and to filling them in. All this is usually the challenge. Like what I reported in those studies, what is usually workload, patients, and lack of availability of these things. You have to bring them. Yes, really have, because there are maybe fewer patients and there are
intentional about it.
And yeah, enough time and so on. But in the clinic, you just want to start the patients. Yeah, that is the workload. If manpower is short, then the workload will be high. Will be high, of course.
And more incentive. When you compare with the workload.
Yes, at even chronic stage, not just acute, that they are destabilized, being resuscitated from AIE to medical ward, and then discharged for outpatient visit. Most of the time, they admit them. They're only there for the rehabilitation. They're there for 2-3 months. Wow. They'll go back home with their so about activities. Yes, and you hardly see patients receiving less than 1 hour. It's 1 hour, 2 hours. So in a whole day, you see the patient receiving like 4 hours rehabilitation every day. That would definitely find out. It will. So that's one of the difference in the stroke lab, and it's almost everybody there. You see patient coming from physio, the patient will go into psychologist office. Wow. Come out, you go to maybe lab. That lab is for just the rehabilitation center to assess some. You are still like.
Thank you.
Thank you very much. I hope.
Thank you, everyone.
We have impacted on a lot. So thank you very
I
much.
wanted to one more test, like the variation, the one that I know, it's basically like a 4-step. Like
There's a first step. Okay.
Yes. You just stand on a normal flat surface with the eyes open, like 32 minutes, 37 minutes. then you close your eyes, still on the flat surface. Then you move to a walky surface, maybe like a mattress or trampoline.
There's a four-step balance test. Maybe that's this test there.
And then it comes to the level. Yeah, so you stand on something. Well, I don't think patients can really stand on that. It's basically for athletes, right?
You see, that's what I said at the beginning. I posted a video of a child running, balancing on a gym ball. This huge gym ball. Develop. You can see I asked what are those
this almost have good balance.
You must be Asian.
So Kazi is working towards practicing to horse riding.
This one has a lot of
So if you
agility.
bring all this back balance
There's
thing.
a face feature.
No, there's no face. No, there's no face.
Has to be an Asian.
Yes, probably. You can see the structure, you can see the hair. Everything looks like yes. They have that good motor skills and they are better than almost anybody. So you can see if you subject this child to all those tests. For me, why balance test is a test that you have an object like a Y shape, and when you move around. Those tests, even though it's been validated currently for patients, but it's developed for athletes and apparently health. So there are some tests that yes, they are for balance tests, but they could be for example, athletes screening them for certain sports. That they want to engage in a certain sport and they must have this level of function. They must have this level of balance function for them to be able to perform that test. That sport. So those are some screening tools they could use. Like when you talk about wobble board, it has to be an athlete. Because I think even apparently healthy when you go I don't think I can balance on this. So there are things tests. So those are the things that we look at if we're choosing the test. What are the items? First of all, what are those tests developed for? Who are those individuals developed for? Like Trump said, it was developed purposely for stroke patients. You can see the instruction they are saying, this side, this side, this side. There are some that will be generic, but they will say it has been validated for stroke or for neurological condition. They will say it has been validated for Parkinson disease and validated for this. In case you can use it for them. But some tests, yeah, just for the athletes, apparently, or for screening for military, screening for some uniform.
Just stand the leg flex one, and then you stand on like a step, something like a raised surface, and then you breathe, and then you have one leg step up.
That was also for sport, yes. I'm not because you are in your orthopedics, so you're familiar with those ones. What I'm very much familiar with are mostly for patients. Yes. Because you are from orthopedic and sports, so at least you should know those ones for the advanced patients. Actually. Right.
You're supposed to make it.
Balance and sequence. That's really for athletes.
And I think maybe like
this
that.
is for patients, huh? Provided it's for patients.
Yes, I know, but not neuro patients.
Yes, not neuro.
It could be orthopedic patient, somebody who had knee injury and is having problem with proprioception. Yes, you can do that, but you can also balance. You can also balance the pivot. Like especially patients with ankle injuries, they usually use for their training. Most of the time. Especially that they have impairment of proprioception. what you're supposed to do is to balance the weight. Yes, you distribute your weight so that you balance the entire almost. Almost. When you try this 3 times, yes. Yeah. Thank you very much. That's fine. Yeah, that's. Yes, 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 yes. Yeah. You try. Wow. And the timing also will be important.
Thank you. Goodbye.
Huh? Those circles. No, the circles.
This one?
Just something like training or something.
Yeah, it could be used for.
Maybe identifying a bigger size and a smaller size.
And maybe also to try to reach to touch. Just like this ladder. Just like the ladder. It can also it can correspond with the.
Thank you very much.
So thank you very much. Yeah.
How much? Thank you.
See you later.
Thank you.
Thank you, sir. Wallahi.
Goodbye.
Your name? Yeah. Where are you studying? Musa Hospital. Okay, I would say Musa. Fantastic. Hello, energy.
Yeah, maybe sometimes. Yeah, yeah. I know something. No,
ana ta wannan yanzu ana ta dai bincika me ya faru an kirawo ba ma san me ba